Нет, специально better done from above or from below. Let's go to the back, post-resurrectum. We have Heinrich von Waldeyer Hartz from, well, he spent a lot of time working on a lot of
Так, все, тут уже товарищи пошли. Да, ура. Да. Алло, доброе утро всем, если кто на связи. Алло. Алло, проверка связи. Нет, у меня нет тут проверки связи. Давайте аудио настраивать.
Алло. Проверка связи. Меня слышно, нет? Раз, два, три.
Хорошо.
Это вы сейчас зашли, да? Так.
Это лекция.
Вы еще не зашли?
Давайте вот этого, если...
Я зашел, но я себя не вижу пока.
Браузер-код пока.
Вот смотрите, я вижу только... включить видео надо. Вот. Yes.
Так, у вас я переименую.
Çok kuruyorlar da kızartmadım çok ama.
Tamam. Good morning.
Hello, good morning. How are you?
I'm fine.
Если я
Okay. Hello.
Hello, good morning.
There is something wrong with the audio. The
No,
meeting will start half an hour time. Is that right?
yes.
All right. So the discussion will be at the end, I hope, or after each several.
After Professor Amjad.
What do you mean by after presentation by Amjad? After each presentation or at the end?
After third.
Sorry?
After third presentation and after fifth presentation.
After each presentation, you mean?
No.
So could you tell me the timetable for the discussion, please?
Discussion will be after presentation of Professor Parvaiz. It will
I don't know when Parvaiz is presenting. Just give me a time limit, please.
The time of discussion will be by your time, UK
Yes.
or Turkey?
Turkish time.
Turkish time, okay, just a second. Так, а если у нас в час, по московскому времени в Турции, по минус 2 часа, it will be 11, 10
Sure.
after 11, okay?
Okay. Do you want to test anything at all now?
No, it's, no, it's okay now, okay?
All right. Okay, thanks. So I will be
okay.
there at 11.
Okay, I text in our group, okay?
Okay, thank you very much.
Bye-bye. You're welcome.
Thanks.
Bye-bye.
Bye.
Так, а вы меня слышите сейчас?
Да.
А вы мне скажите что-нибудь, чтобы я в наушниках слышал или нет?
Раз, два, три, проверка связи. Раз, два, три.
Мы вас слышим. Какой канал мы выбираем? Английский?
Да.
Да, мы выбираем английский.
Какой вопрос? Вот английский нет.
В английском канале будет перевод на английский язык. Это переводчик Дмитрий.
Да. Если докладчик и модератор у нас Рустем Талгатович, да, он будет на английском говорить, он тоже должен быть в английском канале, верно?
Если он хочет слушать перевод на английский язык, то он должен быть в английском канале. Канал выбирается, чтобы
Так,
слушать.
Русский канал уже, наверное, перевод.
На каком языке вы хотите слушать? Вот тот и
Я хочу
выбирайте.
слушать на английском.
На английском.
Значит, тогда английский
Да.
надо выбирать.
Да, хорошо. Спасибо.
Так, микрофон не забываем за собой выключать.
А вот меня сейчас слышно?
Да.
То есть у меня звук идет через наушники, что важно. И динамик будет.
А меня слышно сейчас?
Сейчас
Да.
слышно. И у нас тогда не будет
Да.
хранить.
Ну, просто, да.
Лишь бы наушники 4 часа будет.
По громкости, вот сейчас я переводчик Дмитрий, по громкости как уровень?
Можно погромче.
Нет, там ну, это
Громче?
нет,
нет,
не надо
нормально,
громче,
нормально.
потому что это зависит от громкости на компьютере. У меня очень хорошо, даже может быть чуть-чуть тише.
Ну я тогда могу подальше от микрофона. Все, тогда нас просим назначить переводчиками. Потому что мы пока...
А вы нет, пока не переводчик? Вот это только я вижу.
Роза уже переводчик, я пока нет.
Дмитрий, вы знаешь переводчик?
Да.
Осталось 15 минут уже. Всё.
Да.
Проверка связи. Слышите меня? Эй.
Да, слышим вас.
Хорошо.
Слышим.
В английском, да, все правильно же?
В английском канале.
Всё,
Да,
хорошо.
все правильно.
Всё, значит, здесь Адель Гаш вещать будет. Всё.
Да. Good morning. Good morning. Hello, good morning, everyone. So I would like to check the connection with Professor Amjad. Андрей Альбертович, вы слышите нас?
Прекрасно вас слышу.
Всё, прекрасно. Okay, we are waiting our moderator, Professor Amjad Parvaiz.
Yes, hi, good morning. I'm sure you
Hi,
can
good
hear,
morning. No, it's okay. Good morning.
you can hear me now.
Yes.
Hi, good morning,
Hi.
everyone.
Good morning. The connection is great. So,
Okay.
and Dr. Ayupov is coming and he's here. Звук.
Rustam, hi, good morning to you.
Good morning, Amjad. I'm glad to see you. Thank you. Thank you very much for.
Likewise, I am also very happy to see you and nice to see you that you are well and everybody is safe.
Thank you. Let me to introduce my chief, Adel Ismailov. He is a urologist, a very good surgeon.
Good.
And,
good morning.
Nice to meet you. Good morning.
Nice to meet you too.
Mr. Amjad, so the first presentation will be of Professor Bill Hilt, okay?
Yes, that's correct.
The next, yes, Professor Kuzu, and the third presentation, your presentation. After your presentation, please organize a question session, okay? After your question session, we will demonstrate one movie,
Okay.
short movie, 5 minutes, okay? And after this movie will be 2 presentations, Professor Qureshi and Sophocles, okay?
Yes, that's correct.
Okay, this is first part, international session.
Yes.
So you're welcome to moderate this.
Okay, I think we can do that with Rustam and myself. Maybe.
Yes,
we
of
can
course.
moderate.
Yes, it will be great. Yes,
and we can take questions, and Rustam can look at if people are writing questions, or they're writing anything on the on the chat room, as it were, and then we can put the question across to our expert.
Okay.
Amjad, hi. Good morning.
Good morning, Ayan.
How are you? How is everything?
Everything is good. You look tired.
I am indeed. I was told that the questions will be at around after the presentation, around 11. Is that right? Is it okay for you?
It is still the case. Yes, it is after the first session. Bill will speak, yourself and myself, and then there would be a question answer session about 11 o'clock. That's correct.
All right. Okay. Okay. That's great.
Is that okay?
Yeah, fine. That's fine.
So how are things in Ankara?
It is, tiring, and it is, COVID is very high. Lots of people is infected. So, I don't know what will happen. I just involved this vaccination protocol.
All right.
Yeah, they choose us for the, in the study. So we don't know what we have. We have been injected either placebo or the vaccine. The Chinese one, but.
So you had the shot. You already had a shot.
Yeah. The Chinese one, yes. But maybe it is the placebo. We don't know yet.
Okay.
Yeah.
No, I don't think so. They would give you placebo. Professor.
No.
Real thing.
There is no cheating. No way to cheat. No way to cheat. Yeah.
Okay. So
Yeah.
Chinese.
Yeah.
Are you feeling okay?
Yeah, I am indeed. There is a rectal cancer live surgery going on tomorrow in my university. I will do one open low anterior. The guy who had liver gastric cancer operation 6 months ago.
Okay.
And the other one is the APR and one laparoscopic TMA. Yeah, it will be tired day tomorrow also.
So you will be doing all of these.
No, two cases I'll doing.
Okay.
Cihangir choose the laparoscopic
Доброе
TME.
утро, проверка связи в русском канале.
Have you had a chance to read the paper?
Все отлично.
I've
Я
done
перехожу
the
в
first
английский
read.
канал.
I'm
Спасибо.
making
Yeah, is it
Yeah.
something that I mean needs too much?
No, it will be taken. I think there is a readership for this paper. There are some minor changes I suggest. There are a few more changes I would make, and over the weekend I'll send it back to you.
Looking forward to your advice and the title as well, please. We will talk later. So I'm closing my microphone and the camera. See you then.
Good morning again. So we start in 5 minutes, okay? In 8 minutes. Okay.
So if Leona,
Yes.
if you're hearing me,
Yes.
I think when you
Yes.
start, we can ask Rustam and Ismailov to say Adel to say some things about the conference.
Yes. Yes. Adel Ismailov will open our conference. He will greet everyone, and with Rustem, you will moderate the session. Okay?
And then we can take over, and then you can play his Gil's presentation.
Yes.
Okay.
See you.
And your technical team have got my videos, the short video clips.
Yes.
So I think during my presentation, I probably would stop and just give the instruction that you can play the video.
Okay.
And you can play it, because if I play it from my side, I have noticed that the speed of the internet usually makes the video go slow. So people find it difficult for high definition videos. They are small clips. They're not huge. Maybe when I get to that stage, you can play 3 or 4 of them one after another, and then I can finish off the presentation by showing the slides.
Amjad, we have 2 videos to your presentation. Is it correct or not?
No, I think we send you a bit more than that.
More?
Yeah, I send you more. I send you about 4 or 5 small clips. Can they test which one they have?
Yes. Что пятое? Куреш, да, Куреш. Just a second. Наверное. Mr. Qureshi, do you hear me? Mr. Qureshi, Professor Qureshi. I need так, попросить Yes.
We have to unmute his mic, maybe.
Mr. Qureshi.
You have to unmute his mic or give him permission. Yeah, I think you have to give him permission to unmute the mic.
Can you hear me now?
Yes, we can hear you. That's
Very good. Worth waiting. Huh?
Nice to see you. Are you keeping well?
Yeah, I've still got my pajamas on. What are you doing?
Hello, Mr. Quresh. Good morning.
Good
I'm
morning.
Helena. Good morning.
Morning to
So,
everybody.
we would like to ask you to make audio because we supposed that somebody just delete option at our administrator.
Sorry, what do you need
Okay.
from me?
No, just a second, okay? I will come back now.
Okay.
So you're getting a vaccine next Monday, Taz?
You want to see what it does to me, don't you? Before
Yeah.
you take it.
That's exactly what I'm asking for.
So next week I'll have an ear just here
Yeah.
on my forehead.
I just saw Ayan Kuzu, who had a Chinese vaccine in a trial given to him. He looked really weird, and he said it may be placebo, but his
Was he
eyes are
speaking English still?
yeah, his eyes are coming out.
Yeah. What's happening in Qatar with the vaccine then?
No, they are waiting exactly like everybody else. They bought 200 doses.
200?
200,000 as a first batch in December from Pfizer. But I think they probably would wait a week, see what happens in England, and then.
Yeah, Boris, thankfully Boris has put his
Professor
hand
Quresh,
up and said,
I'm sorry, can you just please get out and then get in again? And
get out?
to the Zoom?
Sign out and sign in.
Yes.
Okay, we'll try this again. See you later.
Mm-hmm.
Сделать организатором. Ну, чтобы он сделал организатором меня обратно.
Mr. Qureshi,
yeah?
Please make organizer, у вас как administrator, like organizer, because you delete the option of our organizer administrator.
Okay, so I'm trying to leave the meeting.
Okay, let's start.
Are we good for the time?
Yes.
Yes.
So yes, please, Adele can take a start and we can start the meeting.
Good afternoon, good morning, good afternoon, dear colleagues. I'm glad to welcome you to international conference. Challenges in screening, diagnosis, treating colorectal cancer are global. These problems exist worldwide. Colorectal cancer takes a leading role among morbidity and mortality in oncology. Today, we could discuss and share experiences in issue relating to the diagnosis and treatment with many invasive surgery of colorectal cancer. I wish you best and hope that the work of participants in the conference will be successful. I give the floor to the Chief Oncologist of Bashkortostan Republic, leading specialist in the progressive treatments of colorectal cancer. Please give it up for the founder on the many invasive colorectal. Рустем Талгач, вам слово.
I think he need to
Рустем Талгач, не слышно.
I'm sorry.
He need
Yes, I'm
Unmute.
sorry.
We can't.
And I'm very glad, dear colleagues. I'm very glad to see you on our conference. I hope that our conference will be helpful for us, and with great pleasure I give next words to my friend Amjad. Please, do you hear me?
Okay, I'm not too sure if you can hear me well.
We hear you. Everything is okay.
But there is an echo. I can hear your voice in echo.
We are hearing Amjad, but we can't identify you because you lost the
Alexei, nice to see you. Nice to see you. Right. If you can hear me, first of all, many thanks to Rustam and his team for inviting me back again, for inviting me in Ufa. Even if it is virtual this time. So thank you for the invitation, and nice to see familiar faces too. Are we okay still?
Yes, the connection is well, and we hear you.
Okay, because I was not too sure. Okay, so I think we will start the first session. The first session is put together as covering the key topics in colorectal surgery. And most of you who are signed in as a colorectal surgeon would agree that the topic's choice is something which is very relevant. These are the choices that colorectal fertility is talking about, probably from surgeon's perspective. We haven't covered the chemoradiation part or wait and watch part in this, but we thought we would do what is relevant to surgical team or surgical staff. So we put together these titles of the talks. This would obviously start off with someone who doesn't need any introduction, a mentor, a teacher, a friend, and an overseeing angel, as it were. You know, whenever I operate, certainly I feel that he's around telling me that it doesn't look right. So Professor Bill Heel is someone I'm referring to. He very kindly have accepted our invitation to come to UFA virtually. And I hope that next year when things are better, he promised me he would come physically as well. So there is a promise from him. I asked him to come and talk to us about anatomical planes for rectal cancer surgery, because nobody knows this better than the guy who discovered them in precision and then taught almost everyone around the world in the last 3 or 4 decades. So we'll start with his presentation, followed by switching our topic from rectum to colon, and ask my colleague, Professor Kuzu, to speak about it. But let's just hear Bill's presentation, which he very kindly pre-recorded with us because of the internet connection worries, and he would be joining us, I hope, for discussion part. So please play Professor Heel's video or presentation of his video, please.
Thank you very much. We start presentation.
Сейчас. Идет звук. Ну, в смысле, вот этот микрофон отключите. Сейчас.
Just a moment.
Так, я выкрутил вам микрофон. Нету, да? Сейчас, секундочку. Сейчас. Я вот тише говорю. Все. Слышим. Проблема.
And just a second, we try to make the voice of the presentation.
Very variable, but the layers in the pelvis. It's a real pleasure to be back in Russia. I've enjoyed my visits to Moscow, the colorectal school, and Professor Sarkov, long-standing friends, and visits to St. Petersburg. What a wonderful city. You have much in your heritage there to be so proud of. This is my
surgery, and most of you who are signed in as a colorectal surgeon would agree.
This is the Champalamo Foundation on the banks of the River Tejo in Lisbon, Portugal. And it's a pleasure to speak virtually from there and start with the concept that the gut is formed within the mesentery. It's really the mesentery that defines the outer limits of the gastrointestinal tract, the midline structure. And that has been the basis for TME. The mesentery and the gut are one organ. Its margins are defined because it is a midline structure. Veins may be very variable, and arteries may be very variable, but the layers in the pelvis and the planes between them, layers are real. You all know what a layer is, but we often call layers wrongly. We call them fascia. Fascias to me are the areolar tissue between the layers.
Английский канал.
So you see there a fascia, and you see the innermost layer is really the outer margin of the mesorectum, and recognizable because it is shiny. Embryology is everything, and as you develop your surgery and you begin to produce perfect specimens, it will be because of the precise way in which you dissect in the areolar spaces between the layers. And we will come back to that dissection at the bottom. We're actually one layer too far out. A plane is a potential avascular space created by dissection. And this particular example is a female, in fact, and you see, if you watch carefully, that we have a long way to go. We use very gentle retraction. That's a heeled retractor. I showed it and labeled it in the last example. It's simply a St. Mark's retractor, narrowed down in its lower segment so that it can get into the bottom of the pelvis, and it lifts forward the mesorectum. If you find the innermost dissectable plane, you are creating a perfect separation between the midline structure, the gut and its mesentery, and the precious surrounds, which are the nerves of sexual function, the nerves of continence, what I call the nerves of pelvic happiness. You lose those nerves and you will be unhappy, and it will be your pelvis that makes you unhappy. There's the bilobed mesorectum lifting up very gently and precisely, and there are the nerves over on the right side of the pelvis. You see the point that they used to call a lateral ligament. In fact, it's not a ligament, it's a point of adherence where a few vessels go in. And turn your eyes to the left, the same dissection on the right, but on the left, you see that the MRI, the great contribution from Gina Brown and others, was that the MRI shows you beautifully, as a dark line on a T2 weighted image, exactly where you are going to be able to create that huge space on the right. Those are the separation zones. That is the holy plane. It's between the gut and the surrounding structures. Beautifully shown by Inés Santiago from Champalamo. The mesentery surrounding the rectum can be beautifully shown, and we can, if it's invaded by cancer, then of course preoperative radiotherapy and chemo are probably indicated. And short course is probably better than long course. So radiology for planning is crucial. The hypothesis of the holy plane, which I originally spouted, if you like, that the midline origin gut and its mesentery covered with a layer of visceral fascia, that would be the areolar tissue, mesorectal fascia, or further up, mesocolic, exactly the same principles for colon cancer. The retroperitoneum and the pelvic side walls are lined by parietal fascia, and the holy plane is between those two. There are areas of adherence, such as we've just illustrated, where the fascia is absent. For example, the inferior hypogastric plexus used to be called the lateral ligament. That's because it tethers the rectum and its mesorectum into the pelvis. And people didn't understand the true anatomy, so they thought there were ligaments there. And I was widely criticized, even ridiculed, for suggesting that what they were calling ligaments were in fact nerves. And I would repeat that the Denonvilliers, which is just outside the tapering lower part of the mesorectum, is a septum or a layer. It's real. It's not that lovely areolar tissue, the cheveux d'ange, the angel's hair, that's between the actual layers. So I think Denonvilliers is a layer and Valder is a layer. And we will show a little of that later. Do we do the surgery open, laparoscopically, or robotically? It matters not. The principles are the same. And it's very difficult to find a truly objective person because it requires so much practice to become really good at any one of these methods that you tend to be biased in favor of the method you like best. The one thing that is common to every method or approach, robot, minimally invasive surgery, open surgery, is that you should find that shiny innermost visceral envelope that is going to provide you with a beautiful specimen. I personally think that the usual way of finding the vessel root first has a slight danger to it, that you will get inside the visceral envelope rather than being outside it. So I've always favored finding the visceral envelope a few centimeters down from the main vessels and working your way up to ligate them. This is a very nice example of all that done laparoscopically using hook dissection. He's looking, Professor Caipescu from Bucharest is carefully finding the shiny package. There it is, and you see the blue line of the superior rectal vein, which becomes the inferior mesenteric vein, and he is in the innermost dissectable layer. If he goes further in, there will be no more nice planes, and he will be tapering into the mesorectum. The innermost dissectable plane, and then you follow that plane down around the mesorectum, all the way down to the point at which you are going to make your anastomosis. You can't say these things too often. It's made more complicated in the tapering lowermost part of the mesorectum because you have two extra layers. They are real things, they are layers. And the one at the front is called Denonvillier's, usually fascia, but it's actually a layer. And the one at the back is called Valdayer. They are white sheets. They're recognizable as white sheets. And this is worth remembering. Denonvilliers in 1837 defined the anterior one, and Denonvillier's septum sheet is incomplete laterally, but it is on the front of the mesorectum and marked in green there. He called it an aponevrose pubiorectal, the puborectal aponeurosis in his thesis in 1837. Professor Williams from Cardiff sent me that because it demonstrates beautifully that there are two layers to this septum. The lateral edge is the defining edge. So it's incomplete laterally and it's tapering medially as you go down. And just lateral to that lateral edge are the crucial nerves on which penile erection depends. So the survival of the race depends upon what is just lateral to those two layers. Coming from above, some of my best pictures, I'm mostly an open surgeon, and you can see there the seminal vesicles. You see a St. Mark's retractor, which is absolutely ideal for retracting the surrounding structures away from the mesorectum. You see the areolar tissue being dissected by monopolar diathermy, and you see the definable lateral edge there. And then a little further laterally, you see areolar dissection, and there is no Denonvilliers just there. That is the mesorectal fat of the anterolateral mesorectum. That was with Umberto Perini in Aosta in Italy, and I must say I'm deeply sorry that he died so young. We had a lot of fun together with him doing laparoscopic and me doing open, and then people deciding which they liked better. This is, I'm being helped here by Brendan Moran, who is lifting the nerve away with the retractor, just top right. You see him easing the nerve away from my cutting instrument, and I'm making a U-shaped cut in the Denonvillier's septum. And you can begin to imagine there might be 2 layers there. But we'll do a little more on that with the aid of the robot. Here is Mark Gudgeon showing you beautifully at the bottom is, and actually we've moved on, and I will show you by jumping this forward that there you are looking into the peritoneal reflection. And then in front of the peritoneal reflection, you've got not just 1 layer, but 2. And we don't always see this. And in many ways, this is many years ago when Mark was just getting to grips. He's now one of the world's experts on the pelvic dissection with the robot. But you see there, it was a dramatically clear illustration that there's another reflection, and it's between those 2 layers. The downward extension of the peritoneal reflection is what used to be believed to form Denonvillier's septum. It actually seems to be in front of it, doesn't it? It seems slightly different. And the view of my friend, who's an embryologist, is that it forms more or less in that line, but separately from the peritoneum. But there is it's almost as if there's another reflection. Do we really understand where the layers, Denonvilliers, we haven't talked much about Valdea, but staying with Denonvilliers, you see some beautiful transanal TME dissection by Professor Masaki Ito. You see he's actually cutting through 1 layer and demonstrating extremely clearly that there are, in fact, 2 quite clear layers. And it's very important. You might even think there were more than 2. But this kind of precise dissection is the key. And I still have not made up my mind whether these things can be better done from above or from below. Let's go to the back, post-mesorectum. We have Heinrich von Valdea Hartz from, well, he spent a lot of time working on a lot of different things. But his fascial layer is often said to divide the posterior pelvis into an upper and a lower space. We forget, I think I've made it clear already, that it is we, the surgeons, that make the space, and the people who dissect cadavers, they make spaces. There are no spaces in the live human. And once you recognize the layers and understand them, you realize that most of the mistakes we make are outside Valdea. Just as they are at the front, we tend to like to dissect in front of Denonvilliers, but we are taking risks by doing so. Now you see the upper and lower space in the slide there, above and below Valdea's fascia. You see here the rectosacral fascia, which is in fact Valdea, they're the same thing. And if we come down in the innermost layer and stay inside it, the black arrow shows staying inside it, you will see here an example of where we have not stayed inside it, because if you look very carefully, now lit rather clearly at the front by the light on the retractor is a white layer, and we are outside and we are seeing bare bone. We are therefore taking a risk. This was only 3 or 4 years ago, and we thought this was a beautiful case for teaching, but we are in fact one layer out. If you look anteriorly, you can see that the white layer is on the specimen. That will mean we have to dissect through it to get back into the innermost layer. We've left a layer on the specimen. And although we're doing very well, we haven't made anything bleed, there are risks. And when we've worked our way round laterally, as we're doing now, it becomes essential that we keep an eye out for the nerves and preserve them. That's another story, but it's all based on the anatomy and the understanding of those layers. Is it not better to dissect in front of Valdea, i.e. to leave it in the patient? And coming down from above, here's the great Amjad Parvez dissecting with a robot, and you will see that he is actually gently easing Valdea's septum off the mesorectum. What he's doing with his dissecting instrument, robotic dissecting instrument, is carefully going through the cheveux d'ange with monopolar diathermy and lifting the mesorectum forward. Coming from below, you have to realize that it is very easy to get the wrong side of Valdea. That each point, if you were to look carefully on the MRI, you would see that my arrows are following the innermost of the possible dissecting planes. Here you have an example. The whiteness on the front of that video is in fact Valdea's septum. And you can see there's a perfectly nice dissection plane outside it, but you can see bare bone. Therefore, Greg Wynn and Ralph Austin from Colchester, they're realizing they're a layer too far out. And for all transanal dissection, it's crucial to recognize that layer. That, you see how thick it is. Valdea's septum low down is a pretty thick layer. And now he's found the innermost dissectable layer. And that will mean that he does not damage the nerves, which is just coming to anteriorly there. And it will also mean that he doesn't get diverted laterally into the lateral compartment of the pelvis. That's a really important piece of video. Just to recap with the MRIs, and you see the Denonvilliers with its lateral edge. You see all those veins in the lateral compartment. If you get outside Valdea, you're inclined to get into that, into those veins and make things bleed. Even possibly cutting the urethra. There have been more than 60 reported cases, and one actually reports cutting the actual catheter. It's worth looking carefully at those layers and understanding that we must dissect in the innermost. The inside Valdea, everything's fine. Outside, bare bone, nerve damage, bleeding, problems. We see here again Professor Masaki dealing with the posterior dissection. You've got the a midline confusion due to the pubococcygeus muscles, which we used to call the anococcygeal raphe. But here you see on the patient's left side, he has beautifully defined an innermost dissection layer. That could be the lower edge of the, if I follow on here, you see again the innermost dissection there. He's just joining up with the abdominal dissection there. Very, very easy, however, to go too far out, and it's essential to have identified the shiny mesorectal layer. The acute posterior angulation can indeed be seen. This is the same sagittal MRI that I showed earlier, but you do see that each of those layers is apparent, and it is the innermost one that we are interested in to protect function. You can see here Amjad Parve again doing some beautiful robotic. So he does both laparoscopic and robotic equally beautifully. But you see him here again staying in front of Valdair and very precisely in the correct plane. And as you go further down, the same principles apply. Again, leaving the fascial layers, Valdair and Denonvilliers probably, inside the patient, unless the cancer is actually threatening those layers, in which case, of course, you carefully go outside them. But if you understand them, then you can go outside them in the region of the cancer threat and clear it. There are various things that we can do with greater precision with the robot. And it's only since I've been watching Amjad and others with the robot that I've realized that there's a lot of deposits of fat between the two layers, between the mesorectal surface and Denonvilliers at the front and Valdair at the back. And there you see where I've put the title, and now I've marked it, that is fat, which doesn't belong on either side. But from a practical point of view, it's probably sensible to leave it inside the patient. That's pancreas, incidentally. In this case, we've not left it inside the patient, but we've stayed in a precise layer. And usually it's probably better to leave it inside the patient because he's now going outside into the layer outside the fat, and you may lose the clue of the areolar tissue. Now, abdominoperineal has its own set of problems, and this is just showing an advantage of the face down position, which gives you a chance. You're looking at the back of the prostate, and above it in the midline there, in the middle of the picture, you're seeing the back of the seminal vesicles. Here we're getting very near to the neurovascular bundles at the side, neurovascular bundle there and there, back of prostate there. The dream to end our lecture for the abdominoperineal of the future is again provided by Amjad. and it's a transanal intersphincteric abdominoperineal. It's actually intersphincteric because it's not a case in which the layers inside the anal sphincter are threatened, and a good deal of time can be spent with the radiology of these various layers. But what you're seeing there are the external sphincter muscles of the anal canal from above with a robot. And this is, I think, it's very sad to have to take out an anal canal in a young woman. This is a young woman. And you can see the anococcygeal raphe muscles at the bottom, and you can see the inside of the external sphincters, the plane between internal and external sphincter. And that's something you will not have seen, I suspect, but it is a very good way of dealing with the correct tumor, but you must be careful, of course, that you know in advance from the radiology that the intersphincteric plane is safe. If we stay to the very end, we get to the point where we can see the skin we see the inside of the skin of the anal canal. And my finger is on the outside there. I'm moving it around. That's the white is the skin of the anal canal there. And the final move that shows you've done the entire operation from above. A very exciting, I think, improvement in the appropriate case. And very rapidly, that young lady was out of hospital only 2 days later. So I'm come to the end of my talk to you, dear friends in Russia. And although I'm happy to answer questions and talk for a while, at the end of my presentation now, and that's me and Martin Schneider, one of the professors in Heidelberg, doing what will probably turn out, since lockdown has probably got me out of the operating room, actually doing the surgery. Finally, I suppose, as I'm getting on in life, as you would realize. But it's interesting that you can see very clearly a layer there that has been cut. And for this very last case, if indeed it turns out to be, we had a fixed tumor, and it was necessary to go outside Valdea's septum there. At 6 o'clock, you see it on the video. And what you're seeing there is the whole pelvic side wall and posterior wall and so on are dissected clean, because we were staying away from a rather extensive cancer that had gone through Valdea. So thank you for having me in Russia. I wish I was there to enjoy some vodka with you, and perhaps we can talk a bit. It's
Okay, can you hear us?
Yes, we hear. Thank you.
All right. I think we would keep the discussion at the end of the first session. So if people, I would encourage people who are listening into it, if they can type in the questions for Rustam to go through, then we can put it to our panel live so they could answer it. Always brilliant to listen to Professor Heel, obviously, who brings us back to the same old school of anatomy, which I genuinely believe holds all the cards for the surgeon. So if we know the anatomy, and the technology and technique can fit around it. So it's a constant reminder for us. So really enjoyed his talk as usual. He's a bit like a wine. I don't drink, but it appears that the older he gets, the better his talks are becoming. And everybody tells me whoever drinks wine, the older wines are always better. So he reminds me of that. With this not so very old colleague, Professor Ayhan Kuzu, who probably is listening into it, I have to be careful. But I would like his presentation next, who's been asked to address a very important topic of mesocolic excision for colon cancer, because our focus have been on rectal cancer for the last 2 or 3 decades, and colon almost was a forgotten entity because everybody believed that colon operation are easy, they have good outcome, but unfortunately that is not the case around the world. So in many ways, this complete mesocolic excision, the central venous ligation, or D2 versus D3 lymphadenectomy have revived the debate once again for betterment of colon cancer outcome. We know that in Russia, in your own country, Alexei Karachun, a friend and a colleague of ours, is leading a very important study, which we very eagerly look forward to, cold study, to tell us that if there is a real benefit in terms of loco-regional control or long-term survival between D2 and D3, we look forward to that results, obviously. But Ayhan would talk to us about the importance of the concept and then the practical application of how to do it, both for open and laparoscopic technique. So maybe we can show his presentation. I heard that he pre-recorded it, so you can play that, please, with your technical team before we move on to the third one.
I would like to thank the Society for giving me this privilege to address what is complete mesocolic excision in this meeting. Worldwide adaptation of all these improved the quality of rectal cancer surgery. As shown here, all these improved the quality, and the quality has been still improving as shown here. But we have a problem in colon cancer. As you see in this graph from Sweden and UK, there is a wide variation in survival from one surgeon to another surgeon. 25% survival variation from A surgeon to B surgeon, A to B. So why this is happening? What is the difference? This is a standard mesocolic excision, and it is a perfect mesocolic excision. And these are quite variable, as you see here. This is perfect specimen and this is not. So the operative approach changes, varies. This is a wedge resection, this is a rib resection, and this is a perfect mesocolic excision. So there is some difference between these specimens. And operation must depend on the side of the tumor, as shown here in these diagrams. Wedge resection is not a proper operation for all these locations. In addition to this, local recurrence is still a significant problem in colon cancer surgery as well. As shown here, it varies from 4% to 20%. And in classic trial, a well-known trial, it is almost 15% in the right colon local recurrence rate at 10 years. So look at this Hill's perfect specimen-oriented surgery. As you see, the embryological planes of rectum, and when Hills followed these mesocolic dissection planes, he created this perfect mesocolic specimen. No ripped, it is shiny, perfect specimen. And when you look at the primitive gastrointestinal tract, the transverse colon, right colon, left colon, and rectum all has the same embryological dissection planes. Embryological planes are same in rectum and same in the right colon. And therefore we have to follow and do an anatomic dissection along the embryological tissue plane, and we have to remove the tumor, draining lymphatics and lymph nodes. And we have to preserve the mesocolic fascias, visceral fascias. As shown here, it is 1 millimeter far away from the visceral peritoneum, and there is a tumor embolus. And if you disrupt this meso, it will spillage and cause local recurrence and bad prognosis. In order to prevent this, we have to create maximum care not to damage the surface of the visceral peritoneum, because underneath this epithelium there is lymphatic channels, and when you disrupt this visceral peritoneum, there might some tumor spillage into the lymphatic channels. In order to achieve better oncological results in colon cancer, Erlangen group translated the total mesorectal excision sharp dissection following the embryological anatomical planes into colon cancer surgery. As proposed by Herrenberger, complete mesocolic excision includes two important aspects: preservation of the mesocolic plane by sharp dissection and removal of the regional and central lymph node dissection. And their results are very encouraging. 5-year disease-free survival in all stages almost 90%, and in stage 3 it is 70%. Encouraging results. And this is not new. After 1 year, Moyen Statesman, Jameson and Dobson reported this and showed how to do a proper mesocolic excision, however, which is significantly neglected since then to last decades. I just want to show some of the anatomical dissection planes. It is a narrated video. Following the full mobilization of the right colon, the duodenum and the head of the pancreas are taken down from the corresponding mesenteric root to get full access to the spiromesenteric vein and the artery behind. Here, the spiromesenteric vein is identified and the ileocolic pedicle is dissected. The most demanding part of this complete mesocolic excision is the central ligation of the Henle trunk. The most common type of the Henle trunk was the gastropancreaticocolic trunk, and detected in 78% of the cases in the present study. Right gastromental vein, anterior spiropancreaticoduodenal vein, and one or more colic tributaries merge together and form the gastropancreaticocolic trunk. Note that inappropriate traction of the mesocolon may damage the tributaries of the gastropancreaticocolic trunk or itself, the so-called bleeding point. This may result in serious complications. Here, animation presents the additional drainage of ileocolic vein into the gastropancreaticocolic trunk. In another case, right colic vein, superior right colic vein, and ileocolic vein together with the anterior inferior pancreaticoduodenal vein drain into the gastropancreaticocolic trunk, in addition to anterior superior pancreaticoduodenal vein and right gastrooventral vein. Another rare variation is right colic vein and the middle colic vein formed a confluence and drain into the gastropancreaticocolic trunk, as shown within the transverse mesocolon. The different variations of the gastropancreaticocolic trunk are visualized here. In 21.6% of the cases, the colic veins did not flow into the trunk, and therefore the gastropancreaticocolic trunk was not developed. In this case, the right gastromental vein and the anterior spiropancreaticoduodenal veins merge together and form the gastropancreatic trunk. And variations also exist in the minimally invasive surgery as well. Here, as you see, it is the ileocholic artery. After clipping the ileocholic artery, we are looking for the ileocholic vein. But, however, ileocholic vein is not accompanying the artery. As you see, ileocholic vein draining into another side. And this is the superior mesenteric vein. Further dissection shows the ileocholic vein, which drains into gastropancreaticocholic trunk of Henle, as well demonstrated here. So variations exist in right colon, and you have to be very careful regarding the vascular variations in the anatomy. Lymphatic metastasization, as we all know, follow the supplying arteries. In colon cancer surgery, pericolic lymph nodes never beyond 10 centimeters. And there is an arcade principle, which I'm going to talk more later. And the third dimension is also important for hepatic flexure and transverse colon cancer, and skip lesions are rare. This is some studies from Japan. They have been doing this radical central lymph node dissection for many, many decades, and they show that in right colon it is almost up to 25% metastatic lymph nodes along the superior mesenteric artery. And for the pericolic lymph nodes, as I mentioned earlier, it is never beyond 10 centimeter. So we have to take at least 10 centimeter proximal and distal of the tumor and resect it. For the hepatic flexure, transverse and splenic flexure tumor, gastroeploic arcus is another way of lymphatic spread. There might be potential metastatic lymph nodes along the gastroeploic arcade, so we have to take those at least 10 centimeter from the tumor edge, as shown in one of the Werner Hohenberger's operation. This is the tumor, therefore we have to take at least 10 centimeter distal colon, and we have to add omentum, greater omentum, and gastroeploic arcus to the specimen in order to remove all the metastatic lymph nodes. Regarding the third dimension, as shown here, hepatic flexure and transverse colon cancers also may metastasize and follow the right gastroeploic artery and may metastasize underneath the pylorus and lower border of the pancreas. So, while dealing with those tumors, we have to remove those lymph nodes as well. This is a transverse colon cancer, mid-transverse. As you see, there's some pericolic lymph nodes, as well as there is a lymph node just underneath the pancreas. In order to do a radical resection, we have to remove the transverse colon meso with the lymph nodes underneath the pancreas as well. This is a study from Erlangen, and as they shown in transverse colon cancer in stage 3, there is almost 16% gastroeploic arcus metastasis, whereas 20% in the infrapancreatic region shown here. And this has also been reported and echoed from Denmark, Hillerød, that 8% of patients with transverse colon cancer may have gastroeploic lymph node metastasis in stage 3 disease. Another important aspect is the number of lymph nodes, retrieved lymph nodes. As shown in this prospective trial, as the number of lymph nodes increases, the survival increases even in stage 3 disease, as quite nicely shown. And this is again reported from UK as well. It is all stage 3 disease. As the number of negative lymph nodes increases, the survival increases. This is very, very important point. So complete mesocolic excision has to be tailored to the precise colon cancer, because each tumor will have a unique anatomy and drainage, and therefore the dissection plane depends on the side of the tumor. So it is different in cecal cancer, hepatic flexure, transverse, splenic, descending, and sigmoid cancer. We have to follow and remove all the central nodes with the supplying artery to the main arteries. This is a quite nice picture of cecal cancer, showing a quite nice perfect mesocolic excision and preserving the window, duodenal window as well, and the main roots lymph nodes retrieved as well. This is one of my open CME operations. This is the superior mesenteric vein, ileocolic vein, and gastropancreatocolic trunk of Henle. This was an advanced cecal carcinoma, so we don't need to remove the gastropancreatocolic trunk of Henle. So we have to take the ileocolic vein and artery. This is the vein first. In some cases, as shown here, vein can be seen first, but however, there are also variations. In some cases, we found the artery first. And this is the ileocolic artery, this is the superior mesenteric vein, and we are removing all the central nodes just around the superior mesenteric vein. And then we divided this ileocolic, and then we follow this ileocolic truncus towards the small mesentery, and then we remove the middle colic vein at root in order to remove the central nodes quite enough. Otherwise, we don't need to ligate the middle colic vein at centrally, just only the left branch, but in this case, we have to do it for technical reasons. And then we divide the small mesentery towards terminal ileum. This is the mesocolon, this is the small bowel mesentery. So we are taking at least 15 centimeter of the small bowel segment proximal to the terminal ileum. And this is the specimen, as you see. This is the superior mesenteric vein. You see, this is the ileocolic. When we ligate it, you see this is the extra additional tissues, regional lymph nodes that we are retrieving by doing this technique. And then we are following this superior mesenteric vein cranially up to middle colic artery. We are not aimed to ligate the middle colic artery centrally, but we are trying to take only the right branch of it. So this is, we remove all the lymph nodes around the root of the middle colic artery and ligate the right branch of the middle colic vein and artery, and this will be a perfect mesocolic specimen excision for cecal carcinoma as shown here. And I just want to show a laparoscopic technique here. This is an advanced hepatic flexure or proximal transverse colon tumor, advanced case, also invaded the meso of the ascending colon. This is the ileocolic pilica, and then we just divide the ileocolic pilica, and then we enter the plane, visceral and parietal plane. We are following and going between them to mesocolic plane, and then, as you see, duodenum is encountered. With the sharp dissection, we are taking down the duodenum from the corresponding ascending colon meso, and this is the duodenum, and then follow it. This is the pancreas, duodenum, and this is mesocolon, and this is the prerenal, parietal fascia. And then, as shown here, this is the superior mesenteric vein. In order to do a central dissection, we have to found the vein, and then we will ligate this ileocolic vein and artery in order to retrieve as much as lymph nodes as we could. This is the ileocolic artery. Divided, and this is the ileocolic vein, clipped and divided. And then the dissection proceeds along the superior mesenteric vein cranially, and then this allows us to find right colic vein. It persists around 40% of the cases. Clipped and divided, and then dissection again proceeds, and then we found right colic artery, and it exists around 30% of the population. And then again we clipped it and divided. Then further dissection towards cranially allows us to find the gastropancreaticocolic trunk of Henle. Since this is an hepatic flexure carcinoma, we have to remove the lymph nodes around the middle colic artery and gastropancreaticocolic trunk of Henle, as shown here. This is nicely dissected and clipped. Clipped as shown here and divided. Further dissection permits us to find the middle colic artery, which is elevated here and clipped and transected as done previously for gastropancreaticocolic trunk of Henle. This is the middle colic, transected. Then we start scatellization of the greater curvature of the stomach in order to remove all the potential lymph nodes at least 10 centimeters within the tumor age. So we are taking the gastroepiploic arcus with the specimen. In order to do that, we have to scatellize the greater curvature. And then we delineate the pancreas, and now we are removing all the lymph nodes at the inferior border of the pancreas. And then we found our dissection plane from below as shown by here. And this is the right gastroemental or epiploic artery, which is a branch of gastroduodenal artery. And we also remove all the lymph nodes at the base of it. And this is our previous clip of the middle colic artery. Now it is fully mobilized mesocolic excision for an advanced tumor. This is the duodenum, this is pancreas, and this is the, as you see here, this is the superior mesenteric vein, and all the clips for the artery and vein together. Surgery indeed quite variable, quite different from one surgeon to another surgeon. The specimen at the upper row, as you see, these are all wedge resection and rib resection. And these are different from this perfect mesocolic specimens. So there is difference between those two. And indeed, the pathology group from Leeds also did a grading system for the mesocolic excision, muscularis propria plane, intramesocolic, and mesocolic, as shown here, perfect mesocolic, intramesocolic, and disrupted muscularis propria plane, and showed that there is a survival difference between the grading of the meso. Indeed, the worst one is the muscularis propria plane. As I showed it before, this is an encouraging results. 5-year disease-free survival is almost 90%. And like rectal cancer surgery, colon cancer surgery in Erlangen still continues to improve. Very much important. And this is our Japanese colleagues. As you see, they show also significant difference between radical D3 dissection compared to D2 dissection. And this is a prospective Stockholm colon cancer project, and they compare with the non-CME period and showed significant difference between the period they did CME. And again, similar data from Norway, non-CME and CME, significant difference in terms of oncological results. And this is again disease-free survival, population-based study, CME, non-CME, CME did better oncologic outcomes. In addition to this, 5 years later, they look at the local recurrence, and local recurrence incidence was almost 8%, 9% better in the CME group compared to non-CME. And here, this is a prospective, non-randomized, double-blind control trial. Again, here, CME is better than non-CME. You could do the operation with any approach, open, laparoscopic, robotic, but don't do this. As you see, it is a rib specimen. It is not good. Although they removed the tumor, there is no meso with the tumor. So it is significantly just obvious that they significantly affect the survival at the surgery. So the patient chooses the surgeon and gains either survival or ruins his own life. There's no doubt that this is one of the masterpieces of Wolfgang van Gogh. It is a masterpiece. But the masterpieces for the patient is those as shown here. These are the masterpieces. This is also a masterpiece, but these masterpieces gain survival for the specific surgeon. So always bear in mind that what is omitted in the first colorectal cancer resection is lost forever, and failure to follow the surgical technique cannot be corrected by any form of adjuvant therapy, chemotherapy, immunotherapy, what else. And I would like to thank all my international colleagues. We did this step-by-step training package on optimized colon cancer surgery, and it is more than 14 hours educational package in 3 DVDs. And I just would like to thank specifically Werner Hohenberger. He trained us in Ankara University. Phil Kirk, he trained us in Ankara University. My anatomist colleagues and my surgery team, Celal Bayar, and the animation team. Thank you very much for allowing me to speak in this international meeting.
Okay, Rustam, okay, if you can hear us.
Yes, yes, thank you.
Would you like to make comments?
Very good quality of sounds. Thank you. What do you think about next presentation? Okay.
In that case, I would do the next presentation. I'm scheduled to do that. So I would start the presentation, as it were. So my talk really is on a minimally invasive approach to rectal cancer surgery. And before I even start my talk, most of you would know that I trained in laparoscopy, and in recent times, like most of us, have changed to robotic surgery. So my focus really would be on a traditional laparoscopic approach and a robotic approach for doing TME surgery, because Taz Qureshi is going to cover the abdominoperineal part in the later talk after this. Okay. So let's see if I could share the screen. And okay, so you have this, you can see the screen now of mine?
Yes, yes.
Okay,
we
good.
see. Okay.
So like I said, I would focus purely on rectal cancer surgery and give you some insight of 2 possible ways of doing it. So the title of the meeting really is a journey from Europe to Russia of laparoscopy. And for personally, on a personal note, this journey began 2011 time, when I was asked to come and operate and speak at Peter Zarkov's meeting, a colleague and a friend of ours based in Moscow, where I met most of you. And subsequent to that, it appears to me that most of you are very talented surgeons and wanting to learn laparoscopy. And surgery was adopted nationally very, very quickly using minimally invasive technique. We traveled in various units in and around Moscow. And then Alexei Karachun very kindly asked us to come and train with his team. We hosted a number of you in Portsmouth at the time where I was working. And that's how the collaboration began. These are the two very memorable pictures for me into your half of the country, which I believe holds the largest statue of a man on the horse that I'm told in your capital city of Ufa. In the region, and Rustam and his colleagues were our very kind, hospitable host in 2014. This is a picture of me with Rustam and Taz Qureshi in his OR. We did a series of workshops at the time and enjoyed your hospitality quite a lot. The picture on the right shows some very familiar faces enjoying the hospitality, as it were, hospitality in your city. So I had a very fond memory of being in your region, and I really hope that everybody stays safe and sound in this pandemic, and we would have opportunity to meet in person as well again. You have done a fantastic job. I have followed the progress of my friends and colleagues across Russia for laparoscopy for a number of years, and asked them about their experiences, their data and outcome. And I'm obviously proud to say that most of you have reproduced, if not better, the results that we started off here in England. So if you ask me the nutshell of the talk in regards to the title of the Congress, it says that surgery doesn't need any boundaries of culture, belief, and philosophy. Surgery have a very simple philosophy, and that is based around trying to do the best for our patient. And it become very obvious that the language of surgery is very, very similar. Language of surgery is on the screen. You saw some wonderful pictures shown by Professor Bilhil and Professor Kuzu trying to highlight what is important for patients. And this is what my talk is aimed at. So the concept really for me is concept of precision surgery. If you look at the previous two speakers, they keep talking about embryological planes, and embryological planes are the roadmap. I genuinely think that anatomy for surgeon is what the prophet for religion means. You know, you need something to make your mind focus, and you need something for you to aim for. And for all of us as a surgical tribe, embryological plane are the key. It is what holds the key for better outcome for our patient. When you look at some of the good surgeons as compared to not so good surgeons, you see it very obvious that people who perform this procedure with minimal tissue handling, minimal tumor handling, and make it look very photogenic, they are more likely to have good outcomes. You ask patients, what does it matter to them? Would they like to have the operation done open rectal way, laparoscopic rectal TME, or robotic TME? They would tell you that they want to come into hospital and leave hospital without their cancer and without any complications. We obviously are interested in living longer, so we are interested in having better long-term oncological outcome. But interestingly, gone are the days when people were only interested in living longer at the expense of quality of life. We are more and more interested now in living better, and hence the functional outcome following a TME surgery is put into question as well. And we have to respect this. You know, Professor Bilhil spent time showing us the hypogastric nerve plexus, which holds the key for pelvic happiness. And that is something which is very important for people who would suffer because of the consequence of the surgery. So this is something that we need to bear in mind. I train surgeons around the world. I had a pleasure of seeing different cultures, meeting different friends, and periodically from time to time, some of you send me the operative pictures. This is one of the pictures sent from East Africa. A colleague of mine very proudly sort of sent this to me and say, now we have adopted laparoscopic approach, and this is the first abdominoperineal resection done in our hospital. And he wanted my comment on this. And as I hope that most of you would agree that except for perhaps the stoma being slightly lateral, everything else looks pretty standard, at least from outside. But that's half of the story as an oncological surgeon. So my knee-jerk response was that, can you send me the picture of the specimen for me to look at it and give you a real feedback, which they sent me one day following my email. And most of you would perhaps agree that this is not an oncological specimen. This is suboptimal specimen that came out of the patient. So this should never be an aim, that we should try to do an operation, no matter whether we are skilled or not, no matter we have oncology or not, at the expense of our patient's survival. This is one message that I want to give to young surgeons listening to my presentation. And hopefully you would have got the clue by listening to the previous two speakers that doing anatomical, embryological correct operation holds the key for better survival for our patients. So please remember this in your practice. I am lucky enough to live through two revolutions in my lifetime of being a young trainee. 1990s, I trained in South Africa and arrived in England. At the time, this was the debate that was going on. You know, open surgery was very well established. People said they could do a lot of these operations very quickly. Oncologically, it was safe, it was cheaper. People and profession and patient accepted this mode of surgery. And I, along with some of my bosses at the time, trying to learn this or learn from them, had to face this series of criticism, which goes around here. This was a new technique, laparoscopy. It was associated with long learning curve. There was some evidence, but not enough evidence, particularly some initial case reports showing us port site metastases made it very difficult for laparoscopists to do it for cancer. Longer operating time was a problem. And certainly in England, where I worked at the time in 1990s, there was a problem of a skill gap. There were not enough people who could train you into this. So you had to look elsewhere. So we British trainees at the time were looking either to North America or more commonly toward Europe or Australia to go and do some fellowships to learn this skill. But interestingly, laparoscopy have stood the test of time. Multiple randomized control studies, including COST, COLOR, Barcelona trial, and then COLOR 1 and COLOR 2 trial, and classic trial have shown that short-term outcomes are better. It is oncologically safe to do it through laparoscopic technique, and it becomes cost-effective when you do out of operating theater cost. So much so that NICE, which is a National Institute of Clinical Excellence here in UK, which produced guidelines for the clinical practice for different specialties, a few years ago came out with a statement saying that laparoscopy should be treatment of choice for colorectal cancer and should be offered to every patient with this disease as a first option. This was a trigger in early 2000s for people to start taking laparoscopy seriously and start learning laparoscopy. So I alluded to this. This was perceived at the time as a threat for most open surgeons, although the trial had shown that this is good, but people were very reluctant to adopt it. And it was not unless the NICE guideline came through that people were forced to learn this, just because they perceive that if they don't learn and catch up, they are probably going to lose patients to a hospital nearby. But the real crux is this sentence as spoken by Professor Bill Heel. There should not be any difference in oncological outcome, no matter whether you do it open or laparoscopically, because biology and the anatomy has not changed. The biology of the cancer stays exactly the same. If I operate in Russia, I operate in London, I operate in Doha, or in any part of the world, the biology of the tumor is that cancer, if not treated properly, is going to catch up with patients, and cancer usually kill people. That's the bottom line. Anatomy of Homo sapien have not changed for the last 200,000 years, you know. So why it should become a different operation with different techniques or terminology? This is a slightly older slide or older data, which I still use. It hasn't changed much since, I must confess. This is hospital-acquired statistics data to give you an idea that how laparoscopic colorectal intervention have improved for nearly 5% at the beginning of 2000 to 2014, or even further along, we are hovering around 60%. So all elective colon and rectal cancer operated in England certainly are about 60 to 65% nationally. But remember, this is colon and rectum together. When you extrapolate the rectal cancer data out of it, the intervention goes down significantly, with about 30% self-reported conversion rate nationally, which is always slightly higher than normal. So what is so peculiar about rectal cancer? Why we are talking so much purely for MIS technique about rectal cancer surgery? Exposure is a problem. And you saw big retractors as used and shown in open surgery, Professor Bill Heel. It requires a lot of exposure, a lot of help, big traction and counter traction. That is a problem. Post-radiation creates its own challenges. Access is a difficult problem, particularly for male obese patient. And in laparoscopy, certainly, stapling device was the problem initially. And if you remember at the initial part of our laparoscopic experiences, people were reporting nearly 17% anastomotic leak rate with increased number of firing of stapler devices. And that was a technical issue for the surgeons rather than the stapling itself. Classic trial obviously hampered the adoption of laparoscopy in England, certainly, because it showed that we had a higher conversion rate for rectal cancer in laparoscopic arm and higher CRM positivity rate, nearly about 25%. Quite recently, there have been a number of studies. This is a la carte trial published recently, or about 2 years now, or in fact more than 2 years, 2015-16 it was published, where in JAMA, where they came up with a quality of specimen assessed between laparoscopy and open surgery. And they showed that perhaps even in T1 and T3 rectal tumor, not difficult, challenging cases, straightforward cases, laparoscopic specimen did not compare as well as the open subspecialty or subgroup of specimen. And they thought that although it was overall the quality of surgery was high, but it was not good enough when you compare both of these. Just about same time, American published a similar trial, interestingly published very close to each other in a similar journal, very prominent name on these, suggesting exactly the same thing. But when you read between the lines, you start to realize some very fundamental, obvious question. This is their trial data showing that in LAP group, you have 12% CRM positivity rate and rectal perforation or specimen perforation rate of nearly 16%, which most of you would agree with me is quite high. The problem was that it is a multiple center randomized control study with some center doing on average of 10 to 12 rectal cancer a year. We know the volume does play an important role, and that was a problem in this study. So if you take randomized control trial, and if you take meta-analysis and systematic review as level 1 evidence, then you could easily say, well, there is enough evidence to say that laparoscopy specimens are not good enough and people should not be doing it laparoscopically. But that's not the case. The problem is some people do this better than others. Even when I spoke to some of the authors in the last paper shown here, they would tell you that they did not have a rectal perforation rate of 16%. It was other centers or other groups. Their perforation rate is well within the norm. So what is required to produce good outcome using minimally invasive technique for rectal cancer surgery? I genuinely have believed for years that operative technique need to be standardized. The treatment, perioperative treatment techniques need to be standardized. And only in that case, we'll be able to compare and deliver a very high quality service for our patients. So why some people do this better than others? This is a Korean trial, which is, people have quoted this, people have spoken about it, and it came just about same time when classic results were showing a very dismal result for rectal cancer. A very well-designed study, T3 cancer, 170 in each arm, people who had mid to low rectal cancer, and they were all post-treatment. Primary endpoint was a 3-year disease-free survival, but they also look at local recurrences, they also look at conversion rate and so forth. So you could argue that this was quite a challenging group of patients to do the trial on. This is a study design. The good thing about this is that they didn't lose any of the patient to follow up. So complete follow-up to report the data, which is very impressive. It shows conversion rate of 1.2% in laparoscopic arm, 2.9% CRM positivity rate, which is very respectable in laparoscopic group, and 4% in open group. When they looked at disease-free survival, no different statistical difference, although the trend is better in laparoscopic arm. They looked at overall survival, similar finding was seen, and similar local recurrence rate between the two. So obviously it is possible to do this better than others. So when these data or these results were shown to us in the West or the European part or Western part of the Europe, the knee-jerk responses, this is in Korea, they are easy patients to operate on. But most of you who have traveled in your lifetime now, and I know Russia have got close link with South Korea and Japan and China. I've met a few of you in the meetings there in recent years. You would acknowledge that they are high volume center with dedicated colorectal practice, and they seek precision in their operating. So it's the whole cultural shift. If you watch a Korean, a Japanese or Chinese surgeon operate, you would realize that they are very meticulous in their surgical culture, and hence they produce good outcome. We should not hide behind the patient characteristics, not being able to reproduce their result in the West here. This is our own data from Portsmouth. This is a publication about 10 years ago. This is colorectal surgery in high-risk cancer patient, comparing laparoscopic arm with open arm in our practice in Portsmouth, showing that they tend to do better in laparoscopy if you standardize the operative technique. These are the high-risk group patients, 2006 to 2008, consecutive patient, people who are age 80 and above, high ASA grade, preoperative radiotherapy, T4 tumor, and BMI of more than 30. It showed that they had shorter length of stay, better short-term outcome, less complication, and reoperation rate, and less 30-day mortality in laparoscopic arm. But the key really is this. The key really is your ability to standardize operative technique. And it gives me immense pleasure when I watch some of my students do this. And some of you do this better than me when I sit and watch you do this. Because the likelihood is that if you repeatedly do the same thing over and over again in a best possible way, you are likely to become very good at it. We produced this international consensus paper. Some of you participated very kindly in the study. You see Alexei Karachun and Peter Zarkov was part of this study at the time. We looked at our own data recently, and this is a publication looking at our first 270 odd rectal cancer consecutive patient done laparoscopically with long-term survival data. And then I asked 3 of my trainees who initially trained with me and have gone on to become independent consultant to contribute their data as well. And this data showed a 5-year survival rate of 83% overall, and then as a Dukes A, B, and C, very respectable long-term survival. Disease-free survival was 84%, similar findings shown in stage by stage. Our local recurrence rate based on this paper was 1.2%, conversion rate was 1%, and everything else was exactly the same. When I asked 3 of my former fellows to give me 1 year worth of their data once they finish operating or doing their fellowship with me, you could see they're able to reproduce similar outcome with no statistical difference between the two. And that's why I genuinely have believed that there is no point being very good at it yourself unless this can be taught and reproduced in other hands. And it is possible to teach and reproduce this technique in other hands. I showed you this slide earlier on. This is fast tracking it from 1990s to 2020. All I've done is change the headings at the top of the same slide. Now the debate have moved from open to laparoscopic, and it has moved to laparoscopic and robotic. Everything else I have left exactly the same way. So if we have to learn anything from the history, where do you think the likelihood is? Where do you think likelihood of this going? So new techniques and technologies are here to stay, but we would only do this and learn this and reproduce it at the backdrop of anatomical precision. And I think this is where the key is. When I adopted robotics in 2013, the first aim was to standardize the TME. We have to standardize the operative steps. Even within those operations, we had modules which we trying to standardize. This is Jamil Ahmed, who wrote this paper with us at the time. He's a consultant now in Northamptonshire. And we looked at standardization of operative technique using an SI system, totally robotic flip arm technique. We also developed a European-wide consensus to have a standardization of robotic TME surgery. So people could learn, reproduce, and compare the results based on the steps of the standardized approach. We've looked at number of what I call marginal gains within the sort of adoption of new technique. This is urogenital function in our sort of data, Sophocles paper. We looked at our laparoscopic and robotic rectal cancer, done a comparative study, and it shows the better score in the favor of a robotic arm in male, sexually active male patients. Now, remember, these are IPSS questionnaire-based studies, and it has an element of subjectivity. So that's why it is important to realize this. And currently, we're trying to run a UROL trial where we objectively can look at their urogenital sexual scores. We also look at a subgroup data, obese patients, how well they do with robotic and laparoscopic technique. We were able to show that obese group have got better conversion rate, less complication, less reoperation, and as a consequence of that, less operative stay in robotic arm. And ROLAR trial have indicated toward this in a subgroup analysis. We also look at high-risk group. This is again Jamil, who wrote this paper. These were the high-risk group done laparoscopically and robotically, 2 groups, nearly 100 patients in each arm, showing better sphincter preservation rate, reduce blood loss, less conversion, and less hospital stay because of the less complication in the robotic arm. So it is possible to do this. I don't know if I get out of this for a minute and see if I could play a video from this side. Or you guys can play a video. Can you sort of see me now at the moment? So you have a first video that I sent to you. If your guys can play that, the robotic video, and then perhaps it would play better. Otherwise, I'll play it from my screen. I have no problem.
Okay, Amjad, we are ready to start video. Just a moment, please.
Okay. The first one, the first of the 2 that I sent. Yeah, so this is a locally advanced cancer, T4, done only 2 weeks ago in a woman with uterus involved into this. So this is the pelvic part that I'm just showing you. And the idea behind this was to do, I don't know, are you able to see it flowing, or is it blocking or going slowly? Because on my screen, it looks like this is going very slowly. Okay, this is better now. So you could see this is the same embryological plane that Professor Bill Heel and Ayaan Kuzu was alluding to. This is an anterior tumor invading the left tubo-ovarian complex and the uterus. This was a big undercall on MRI scan because they said it comes close to it but didn't involve the uterus. So you found this as a as an intraoperative surprise. So but the anatomy and everything else stays the same. You do a TME with en bloc resection of uterus or hysterectomy with bilateral salpingo-oophorectomy, as it is known as technically speaking. Remember, robot is just the tool. You can approach the same tumor using laparoscopy exactly the same way, because the anatomy would be exactly the same. So, but you could see perhaps that what robot allows you to do is to do this much more precisely, or see it much more precisely, and then use the advantage of angulated hand. Women obviously are technically slightly easier because of the wider pelvis. Male have got a big advantage for robotic techniques, particularly the male obese patient at the pelvic right side wall. This is right and left, both broad ligament and ovarian vessels taken. You can use energy source, but I tend to clip them. If I could name them, then it's easier to sleep. Again, the key really is this. The key really is the anatomy that dictates the operation. Robotic or laparoscopy is just a tool. And the tool would hopefully reproduce the specimen, which should be complete, which should be intact without any denting in the mesorectum. So you are now heading toward the uterine vessels. There you could see coming off the internal iliacs. The key really is, because robotic arm is very strong, you can almost distort the anatomy if you pull too hard and pull the internal iliac in. And you probably would see it more clearly when you are trying to do this sitting on a console, because it is a very strong arm that you have to pull specimen forward and backward. Once you've taken the uterine vessel, you go further along onto the pelvic floor. And now with the gauze inside the vagina, you can cut the back wall of vagina using the diathermy scissor. You would see the gauze just there now. And the key really is that once you have divided the interior wall, and as you are dividing the back wall just here, then you have to stay parallel underneath this. So you go parallel to your specimen still, not to cone into the mesorectum. And after you've done the whole TME, as you could see it here, divide the row rectal tube using a stapler, in this case, a Da Vinci stapler, and then taking the specimen out through the vagina, closing the hole, and then doing the anastomosis as you would normally do. Obviously, it allows you to have no extraction site as you have taken the specimen from below. So the idea of sort of showing you this video is that the anatomy and the surgical steps remains exactly the same, even if I have a different tool of doing it. And then you do the anastomosis, as I said, you put the anvil in and you do the anastomosis and do the flexi. So if we can play the next one, if you have it, please, the next video, you could see the specimen and you can let the specimen run. You can see a completely intact specimen with uterus attached to it. So let's play the second one if you have it. Otherwise, I'll finish off my talk by...
Just a moment. I'm
okay.
What video you want to?
Just anyone you play, doesn't really matter. This is good. This is a laparoscopic approach. As you could see, doing the anterior dissection under the seminal vesicle. This is outside the Denovellius fascia. Again, traction, counter traction with the left hand, and trying to stay parallel underneath outside the Denovellius fascia in this case. Diathermy setting is very low. It's about 20 watts, trying to stay parallel, going parallel to the specimen. And then at given stage, when the fascia fuse the back of the prostate, you can divide this fascia. If it's a posterior tumor, you can divide the fascia much earlier to minimize the risk of the damage to the nerves. So again, it's patience that you need. You can't hurry this operation. You could just about see this. This is the front of the Denovellius fascia that I'm touching and trying to stay outside. You could do this by being very patient, trying to follow the anatomy as it were. it is obviously easier with the angulated robotic arm and the better stable view. This is the edge of the Denovillius fascia, just here, as Professor Bill Heel was showing you. And this is where you divide it. This is the edge. And if you try to stay outside the fascia, just at the edge, this is where you damage the neurovascular bundle. So again, the problem is to show the operator with a 30-degree view, exposure, traction, counter traction. This is the edge of that fascia. You could just about see it here. Again, it's an operation in the rim of air around the specimen. So if you could reproduce this operation, staying in the rim of this air, you have done a reasonably good job. You could just see this. I'm touching the fascia anteriorly, making an incision. Now you would see to divide the fascia here, just there. Just there, you could see almost 2 layers as shown in the previous videos. One attached to the front of the rectum, other one goes at the back of the prostate. But if it's an anterior tumor, particularly if it's an anterior tumor in this area, you have to stay outside for very long way, trying to keep a layer at the top of your mesorectum. Again, you can just see as I divide it, it becomes almost released from the specimen for you to progress a bit further. So it is possible to reproduce your operative technique using laparoscopy or robotic, as long as you respect the embryology. If you have any other videos that you have received from me, you can play it. They are short clips.
We have 3 videos.
You can play them one after another.
Okay.
They're about 15 seconds each. This is just to emphasize the specimen. So again, this is the TME in obese patient, post-chemoradiotherapy, really difficult, challenging case. And what I want to emphasize is this: I have divided the specimen now. I think this is probably the same video, yes. And looking at this right at the end, done laparoscopically, done in Belgrade, I think, or one of the towns in Serbia as a part of a LabSerb training program with my colleagues and friend from Serbia. This is the specimen that you want to look at. This is the specimen you want to assess very, very carefully, that there is no coning of the mesorectum and the staple line comes where the mesorectum finish. This is an important thing to remember. Even in obese, technically difficult patient, this is the goalpost which we are trying to achieve, rather than trying to do this operation laparoscopically alone. Let's play the next one, please. This is division of the Denovillius fascia. You can play the same. Yeah, that was good. Yeah, again, dividing the Denovillius fascia. Just to give you an idea, different patient, T2 tumor, no radiation still, but you could see how easily you can see these layers, divide them, and then try to stay parallel underneath this. You notice that the technique is very, very similar. It's patient's back of the hook, gentle touching to separate the embryology. Embryology and the air would lead you into this. I'm trying to point out, it is done in one of the congresses somewhere. We're trying to show the back wall, and then you're trying to stay going parallel like this. Again, the whole idea of this is to circumnavigate the specimen before you divide it. Play the last video, please, now. So this is the last video, just to give you an idea of it is not only just the specimen that you remove. What you leave inside the patient is a surrogate marker of how well you have done the oncological operation. So again, 2 staple firing. And then as the specimen comes back, as you would see it, you obviously want to assess your specimen. So this is a complete specimen. Intact mesorectum, going all the way, smooth package where the TME plane finishes. And then you look at what you are leaving behind. What you're leaving behind is intact presacral fascia, 2 hypogastric nerves, and you could see just a layer behind this fascia are the presacral veins and the staple line, which is from 12 to 6 o'clock. This is just to give you an idea. Thank you very much. I'll just finish off this presentation by sharing the slide with you. Then come out of this, please. So if I have the screen share option back again. Okay, here we are. So I'll finish off by just showing you last few slides. So just finishing it off, this is Sohan Kim's data from Korea, looking at laparoscopy and robotics, looking at long-term survival, and showing us that perhaps there is a survival benefit if you do them robotically. Of course, this is a single center study, which need to be reproduced and replicated elsewhere. So in conclusion, I genuinely think for MIS surgery, precision remain the concept. MIS approach provide the best tool, no matter whether you do it laparoscopically and robotically. There are marginal gain with the use of robot in subset of patients, but the gains are very, very marginal, and they come at the expense of very dedicated practice, high volume practice, and standardization of operative technique. And the idea is this, that no matter how we do it, the specimen that needs to come out of the patient look very, very similar. This should be the aim of how we operate on our patients for rectal cancer. You know, I'm showing you series of these specimens done laparoscopically, robotically. It makes no difference to me as long as the specimens that are coming out are consistently similar. I alluded to marginal gains, and they come with purposeful practice. I'm very grateful for Rustam and his colleagues, and it's in a way, it's nice to sort of see you, even if it's virtually, to be part of this wonderful meeting. And thank you very much for the opportunity and listening to me. I'll finish here. Thank you.
Thank you very much, Amjad. Thank you. We saw gold standard of colorectal surgery, robotic, laparoscopic. Thank you. And we have time for questions. Please.
So I don't know if Professor Heel is on the line. Professor Bill Heel.
Yes, he is.
And Professor Kuzu.
Yes.
Do you have any questions from the audience sent to you?
Arsen Osmanich, any questions from you? Звук, Arsen. Amjad, I have a question for you.
Sure.
Have you some technical secrets how we can avoid damage? I'm sorry. How we can avoid damage of fascia if you have heart patients, obviously maybe after chemo radiation therapy? What is the principles of mobilization in these cases?
So TME done following chemoradiation using a laparoscopy approach, for that matter, or robotic approach. For me, the operation and the anatomy does not change. The challenge may be added on, and the challenge really is two. Either they have a lot of edema and water that makes the monopolar diathermy slightly less effective. It produces a lot of smoke. And particularly if I'm operating in a narrow male pelvis, this smoke become a problem for a vision. You know, you can't see that very well. Or they have a very bad fibrosis if you're operating in the window, which is a bit longer than usual, let's say 16, 17 weeks following treatment. So then the fibrosis become a problem. One of the problems you can solve as a surgeon with a bit more patience. The other problem, you need the help of your radiology colleague. The edema problem need your patience, it needs a gauze or a swab that you keep mopping, and it's just taking your time. I really can't emphasize this more. The frustration for doing it laparoscopically in challenging case is always your inability to progress the way you want it to. And then in doing so, then we make bad decisions. We tend to shortcut the operation. We try to come maybe using energy source like harmonic scalper or ligashore or thunderbeat, you name it, because we want to progress the operation. We want to get on with our work. So the edema problem needs a gauze, a constant gauze, a suction, patience. The fibrosis problem need help of your radiologist. So he or she should be able to tell us that this is the fibrosis at the margin rather than the true tumor. You have to believe them. They are your eyes before you go and operate. Because seriously speaking, I find it very, very difficult to differentiate by just looking at the pattern, either with robot, laparoscopically, or even by hand. My colleagues who say, oh, this is a lot of fibrosis. If I convert this, this would become so much easy because I can feel. I can tell you it is very, very difficult to feel and differentiate between intense fibrosis and positive margin after chemoradiotherapy. So I think this is an illusion people allude to. What we need is a very good radiologist who tell us that this is a TRG1 or 2 and the margins are clear and this is the fibrosis you are shaving around. So that's why we rely very heavily on our MDT. Maybe we can invite comments from Professor Bill Heel, importance of MRI scan and perhaps how you can differentiate between intense fibrosis versus a sterile margin, for example, intraoperatively in open techniques. It would be interesting to hear his comments.
Well, it's, as you say, Amjad, one of the most difficult things, except I would say after 50 years of rectal cancer surgery, that if you use the simple principles, I tried to start with very simple principles of traction, counter-traction, and thus opening where you think you should dissect, that if you see you using monopolar diathermy, I'm assuming, which is what I've always used, and I know you use, and you've shown us, I think if you can find your way down an acceptable surgical plane, you will usually find that is a clear margin. And would you agree with that, Amjad?
Yes. Yeah, you're absolutely right. If it looks familiar, if it looks in the plane that you have shown all of us, for example, then we are reasonably comfortable that we would get a clear margin.
Yeah.
The only problem comes, for example, where the margin was closed and there is intense fibrosis.
Yes, I understand that's what we're talking about, but I of course, I showed you nice, easy, well, they're not easy ever anywhere, but sometimes it all seems an absolute picnic, and in all directions there is a lovely white layer and the plane turns into a space, and you're quite happy with the nice shiny specimen within and safe nerves outside, and that's all joy. And then the last case I showed of you doing, that pelvis was solid with a white, a rather hard tethering tissue, which is somewhere between fibrosis, and you wonder whether it's cancer or not. But actually, you were using your experience and just very gently with your electrocautery tip, you were just finding in the middle of that whiteness somewhere where you went instinctively. And you nearly always get a clear margin doing that. So I'm always asked, how difficult does radiotherapy make it? And the answer isn't so variable. Sometimes it has made it easier. But more often it has created that, that white tissue, desmoplastic reaction to the tumor, some people call it, but that's only giving a difficult name to something which is to the surgeon just a little bit of a worry. I'm not in a lovely open plane, but I am in white, which just could have cancer there. But I think if you're just about to cut into cancer with a little bit of experience, you actually find that you know that this is about to happen and you back off, perhaps, or you try and go further out. But I suspect, as with the distal margin of a rectal cancer, I wondered how close you can go post-radiotherapy. But again, I believe we are quite fortunate in the sense that if we think we're likely to be just clear, we usually are. So long as we've looked at it, seen it, and used our judgment, I think you will usually, if you stick with the things we've talked about this morning, you will usually end up with a clear margin. And I was pleased to see early in Amjad's presentation a referral to a series which had only 2% involved margins, and that was a mixture of advanced tumors, I think. Yes. Well, if you can keep your involved margin rate down below 5%, preferably below 2%, I think you'll be doing good surgery. Right. Do you agree with those ideas?
Yes, I do. I concur. And just leading into this, maybe to the benefit of the surgeon listening around Russia, in a simple one-liner answer, what would be the optimum time you would like to operate on following chemoradiotherapy, in your experience? Prof?
You asking me?
Yes.
Well, to be perfectly honest, I think it gets easier. I mean, if you're going to have a difficult plane, it's usually a little bit easier a month later than it is earlier. So okay. I'm always, my second opinion when asked to wait a little bit longer if they are wondering whether they might get a complete response and avoid surgery altogether, I nearly always say, well, let's wait for another month and see, because the surgical part of the answer is that I get the impression that difficult cases post-radiotherapy don't get more difficult. They may get a little more fibrotic, but if you apply the rather pragmatic approach I've just described, I think they probably tend to get easier with the passage of extra months. What do you think about that, Amjad? Do you agree or disagree?
I have to agree, because I often operate on these people which are waiting longer, hoping for a complete response. And I agree. Sometimes the longer we have waited, the fibrosis turn into edema and it become a bit easier. That's correct. Now, Rustam, have you got any more questions from the audience writing to you?
Yes, we have questions from chat and from Zia. What is the percentage of nerve damage in post-chemoradiotherapy patients during surgery? I think it will be interesting to know opinion of all previous lecturers, previous presenters.
So, Prof, I'll start with you. What figures would you quote are the risk of having nerve damage following a TME, particularly after chemoradiation? Would you have any ballpark figure that you can quote to patient in consent process?
I think you would be, well, correct me if I'm wrong. I'm not sure that there's any really reliable publication on this. Peter MacDonald and I published about 50 years ago our initial impressions with open TME before radiotherapy came along. And we said that there has to be a 1 in 5 risk of damage, even though I thought I was doing really good TMEs. And that would be higher, 1 in 3, if the cancer was an advanced one. And in those days, we only occasionally gave preoperative radio. We've never given postoperative radiotherapy, incidentally, not prophylactically. We might treat a local recurrence with radiotherapy if we got one, but we would only ever give radiotherapy before surgery. And if we did, it would be for an advanced tumor. And it is, of course, dependent upon how extensive the cancer is on the MRI. So it is really an individual prediction for an individual patient. If you have a huge fixed cancer deep in the pelvis, you must be considering taking the nerve plexuses because they're actually invaded by cancer. And that will be a difficult decision made on the MRI. And that you might have to predict almost 100% loss of sexual function. Okay. But in most of them, you would be saying, well, I think it is better than 50-50, that you will still be able to have sexual activity after this operation, but I cannot promise. Okay. I don't think we have the hard data. If we do, I'm not aware of it. If anybody else is, it's a rather good expression, hard data. I don't think we have actually got anything more than the common sense approach I just gave. And my guesswork, what's my guesswork about quarters and halves, Amjad, you think?
Well, I think you're right. There are two difficulties. The difficulty, like you mentioned, is radiotherapy often makes it worse. So even before surgery, the damage may have already been done. And then, like you said, the data that exists out there is quoting roughly between 10 to 30%, but some of the retrospective data pushes up to 60-70%, but they don't take into the account of effect of radiation, effect of locally aggressive cancer, and radicality of surgery for those particular cancer, because those subgroup would inevitably have nerve damage. So I agree, the quoted figure or the common sense figure are about 1 in 5 or 20% of the time you would say that you're likely to have some form of dysfunction. Any other question, Rustam?
I think before we leave that, Amjad, we've got Ayhan Kuzu, who is a very experienced surgeon dealing with a lot of advanced cases.
Yeah.
I wonder how he would answer that question.
So you say, has he got any hard data? Ayhan, can you hear us?
We're not hearing you. Ayhan, you've got to unmute.
They allow me to speak, Bill. Hi.
Hi, Ayhan.
Great talk. You're both my masters, so I learned a lot from both of you. And as you mentioned quite nicely, that it is multifactorial, depending on many factors: radiotherapy, age, associated diseases, site of the tumor, anterior location to posterior, and the level of the tumor. And again, I don't have a very hard data. There is after the radiotherapy and according to the patient age and gender, it's get effects. So consent must include this problem and clearly specify that patient that there might be a problem with it. In our series, it's around, for sphincter saving, it's around in the patients who receive radiotherapy, it's around 20, almost 20%.
Okay.
One final thing, and that is that if you decide to give your patient radiotherapy and she is female, you can be quite sure that she will end up with quite a substantial impairment of sexual function because the vagina becomes so dry. And until we can focus our radiation in such a way that it does not directly dry up the vagina, I think that's a much under-mentioned factor. And it's a very good reason, particularly in a youngish woman. And I listened earlier in the week to the reality that we are all seeing more patients between the ages of 30 and 50. This is possibly an international trend which will be very important for our specialty. And I think it's a very good reason for not giving radiotherapy unless you have to a youngish woman or a youngish man. It's likely to take quite a severe toll on their personal lives.
Okay, thank you. If Rustam, if he is not there, I can ask a question to Ahyan regarding his presentation of CME surgery. So if people would like to know from you that how much is the proficiency gain curve or the learning curve changing your operative technique from the standard complete mesocolics, from standard surgery to a CME surgery in a radical way that you demonstrated, and then perhaps changing it to their minimally invasive approach? Have you got any handle, because you changed from open surgery to laparoscopy? How many cases you would say to people who wish to do the operation you demonstrated, they need to be able to master this or become proficient at?
We are lucky in that sense that we have Werner Hamburger in our clinic, and we did live hands-on courses 4 times with him, and we learned how to do an open CME at the beginning. And afterwards, we started doing some anatomical work, looking at the variations that I presented before, showing that there is no normal vascular anatomy in any site of the colon. There are always variations. We have to look after variations. So at the beginning, we start doing open CME following Werner Hamburger. And we are, our university, lucky to have you in our department at least 7 or 8 times that you traveled and showed us how to do properly the minimally invasive surgery. And then we turn to that part. But ours are a little bit different from the rest of the world because we have the Werner and anatomical work and still carrying on and yourself. So in our hands, it took, 2 to 3 years to change open to laparoscopic. For the open, after the completion of the Werner's 4 cases, we started, straight on, So we done at least 70 cases, something like that. And after yourself, that we can, for ourselves, we thought that it is the way oncologic surgery can be done minimally invasive. I have some terrible experience from US showing some surgeons, the planes and the things. And then I think that minimally invasive surgery that way is not good. But after seeing your handling the embryological planes, then we change it to the laparoscopic approach. And since then, we have been doing laparoscopically. But still, if there is an advanced case, we do prefer open because in order to, remove the tumor outside the abdomen, you need, again, an incision and things like that. Although intracorporeal and financial may be a solution for that. Okay. But it depends.
Thank you. Rustam, have you got any questions from the chat, from your colleagues, before we move on to the last 2 talks?
May I ask one question, please?
Yes. Hi, Arsen is here.
Nice. Hi, nice to see you. My congratulations for a nice, as usual, presentation, Amjad. You showed us the multivisceral resection with robot. So my question is connected with multivisceral resection. How do you think, is it possible to use it in routine clinical practice with mini-invasive approach? Multivisceral resection, or is it safe, or maybe you not recommend it to do in routine clinical practice? Yeah.
Okay. Well, Thank you for the question. I think this is very relevant question, and part answer of this is given by Ayaan Kuzu, for example. So if you ask the advice, it has to come at the back of the experience your clinic or you have for managing locally advanced cancers, either open in the first instance and then having enough laparoscopic skills to be able to reproduce that operation. So for example, in our clinic, in our hand, or certain other clinics who do laparoscopy routinely now, they probably would still tackle locally advanced cancers with laparoscopic approach or robotic approach, because this is their normal practice. Now, having said that, there is a pragmatism around this. For example, if the specimen is such a huge specimen that even if you have done a minimally invasive approach and you are making 10, 12 centimeter cut to take the specimen out, perhaps it makes no sense. We certainly have looked at our data. We have got over 120 locally advanced colon and rectal cancer, particularly, not colon, rectal cancer, where we looked at and compared them with our series in UK, done open in the same unit, historical series though. And we demonstrated that it is safe to do it with acceptable R1 dissection rate, acceptable morbidity associated with it. But we acknowledge that this was at the backdrop of having an experience of laparoscopy of over 2,000 cases over 10 years. So there is a huge expertise within the unit to be able to do it. So certainly it is something that I won't recommend for any unit doing laparoscopic surgery in the earlier part of their experience and say, go ahead and do it, because this would have consequences, and the consequences are usually paid by the patient with suboptimal cancer surgery or intraoperative problem or perioperative problem in terms of complications. But when you move the goalpost and ask the question at expert level, is it feasible? Is it safe? Of course, the data has been out there to demonstrate it is safe, it is feasible, it has similar oncological outcome as compared to open surgery in selective hands. I hope I've answered the question.
Thank you very much, Amjad.
Okay.
And Ilya, please.
Yeah, if you have any questions also on your chat, because I'm aware of the time, because we are overrunning this session and I know your colleagues are waiting.
Yes. And maybe we return to our session after a short break.
Okay.
Yes. Okay.
When would you like us to reconvene? Can we just go on to Taz talk, or you want to have a break?
After 5 minutes, we return to our session.
So we will speak about extra-levator abdominoperineal resection, and I would very much value both Professor Kuzu's and Professor Heal's comment into that particular technique, because they both have got very good experience, and Taz would show us his experience and his technique as well. So please, see you in 5 minutes, all of you. Have a coffee break or a little loo break as it is. Okay.
In 2003, Ethicon continued its legacy of leadership and innovation by introducing coated Vicryl Plus antibacterial polyglactin 910 sutures, the first commercially available sutures with antibacterial protection. Since then, we have introduced Monocryl Plus antibacterial polyglycoprone 25 sutures, PDS Plus antibacterial polydioxanone sutures, and Stratafix Symmetric PDS Plus knotless tissue control devices. This comprehensive portfolio plays a key role in the wound closure growth strategy by giving surgeons an appropriate choice for each tissue type, such as organ, fascia, and skin. These sutures were created to help surgeons address a key risk factor of surgical site infections, SSIs, the most common healthcare-associated infections among surgical patients. Preventing SSIs is a key part of the wound closure growth strategy, because it can have a significant impact on the surgical goals for each tissue layer. SSIs delay healing and can have a negative impact on cosmesis, a key goal for skin closure. Preventing infection is also a key goal in fascial closure, as SSIs can lead to wound dehiscence. In fascia, infections can lead to wound dehiscence, a rare but catastrophic event that can have a significant negative impact on the patient. In addition, SSIs can have a serious impact on patients, increasing their risk of morbidity and mortality. SSIs can also be a serious burden on the hospital by increasing lengths of stay and readmission rates, as well as impacting patient satisfaction, ranking, and reimbursement. This makes SSIs a serious concern for all hospitals and surgeons. There are multiple risk factors associated with SSIs, and many preventive measures have been put in place to control them, but some risk factors still remain. One of these uncontrolled risks is the suture itself. All sutures are foreign bodies and can be colonized by bacteria. 70% of all SSIs begin at the incision site. Bacteria enter the wound during and after the operation and immediately begin to multiply. The body's defenses will try to fend off this attack. However, the bacteria can adhere to surfaces of implants, such as sutures, and form a biofilm. A biofilm promotes rapid bacterial proliferation and protects the colony from both host defenses and antibiotic therapy. As a result, a biofilm makes the infection more difficult to treat and causes the infection to spread deeper into the body. In order to address this risk factor, PLUS antibacterial sutures are either coated or impregnated with ErgoCare MP, the purest form of triclosan. Triclosan is a broad-spectrum antibacterial agent that has been used extensively in other medical applications for over 40 years. Because they are made with medical-grade triclosan, PLUS sutures eliminate bacteria around the suture site, creating an effective zone of inhibition which has been demonstrated by in vitro studies. This inhibits bacterial colonization of the suture against the pathogens most commonly associated with SSIs, including Staphylococcus aureus, S. aureus, methicillin-resistant S. aureus, MRSA, Staphylococcus epidermidis, S. epidermidis, methicillin-resistant S. epidermidis, MRSA. In addition, monocryl plus sutures and PDS plus sutures are active against Escherichia coli, E. coli, and Klebsiella pneumoniae, K. pneumoniae. Support for plus sutures is growing. Plus sutures have been studied in over 11,000 patients across 27 trials. The recently published Wang meta-analysis studied 17 randomized clinical trials and found that plus sutures reduce the risk of SSIs by 30%. We have created evidence briefs summarizing the pivotal clinical trials, including the recent meta-analysis by Wang. These are meant for training and education. You can find them on SharePoint. Any concerns that surgeons may have surrounding the differences in handling characteristics between traditional Ethicon sutures and plus sutures can be addressed by clinical study data. These data show that plus sutures provide the same excellent handling and performance as surgeons have come to expect from traditional Ethicon sutures. In one recent randomized controlled trial, RCT, over 94% of surgeons rated the handling of plus sutures as very good or excellent. Now surgeons can continue using their trusted Ethicon polymers and get the added benefit of antibacterial protection without sacrificing the handling or performance that they've come to expect. Since its clearance by the FDA in 2003, outside of 2004, over 140 million strands of Ethicon Plus antibacterial sutures have been used in surgical procedures worldwide, and use of the product is mentioned in infection prevention guidelines supported by the Association for Professionals in Infection Control and Epidemiology, APIC. Our comprehensive portfolio of Plus sutures plays a key role in the wound closure growth strategy by allowing us to offer surgeons a comprehensive portfolio that will help achieve their specific goals for each tissue type. For more information, please see the skin and fascia marketing guides and videos available on SharePoint. Thank you for taking the time to review this Plus Sutures information.
Amjad?
Yes,
Okay.
we're back again. Okay, so if we are back again and you can hear me, Rostam?
Yes, we hear you, and I think that we are ready to listen presentation of Tas Qureshi.
Yes.
Okay.
So it is an immense pleasure to ask Taz, who's a colleague and a very good friend, of course, a friend of UFA as well, because he's been to your center, and I'm sure he still remember the hospitality of Bania that you offered him. You often talk about that. I'm looking forward to his talk. He would talk to us about extra elevator abdominoperineal resection. Is it a must or a necessity or a tailor-made option for low rectal cancer requiring an APR? So over to Taz. Look forward to hearing you and hopefully having a discussion following this.
Amjad, Tas look very good after Banya. Yes.
Yes, of course. And I think he needs to get some more Banya to stay good. So maybe we need to bring him back to Ufa.
Right. Good morning, everybody. Can you hear me?
Yes.
Good. You know, this is the problem with Banya. If you look at everybody's picture, I'm the only one that looks older. Everybody else looks young. So Banya affected me in Wales, you'll never know. And I have to say, I've never walked the same since, but that's another story. Now, look, before I start my presentation, I'd just like to thank everybody for inviting me to come and speak. You know, we're in a very sort of hallowed audience here with the professors Heald and Ayun and Amjad. Rustam, it's good to see you. It's been a long time, probably too long. And I'm seeing other friends as well, Alexei, Arsene as well. And I'm sure there's other people, and I'm sorry if I've forgotten your names. Now, what I'd like to do, can we share the screen? Are we able to do this? Can somebody share my screen? A bit like Amjad's? Or shall I do it from here? Shall I do it from here?
You have to do it from your side at the bottom. Yes.
How does that look?
Looks very good.
Can you see that? Very good. Okay. All I can say is Professor Parvez's face in the middle of my screen. I just need to minimize that for a second, even though it's a very pretty face, but let's just minimize that. Okay, what you don't know is I had to quickly go and put a shirt and tie on because, you know, the professors were looking very smart. But anyway, I was asked to talk about extra elevator APR and whether it's a choice or a necessity. This is a picture we're familiar with. The thing I remember about UFA isn't just the Banya, it's the food and the friendship. And if you look at Amjad and I, we look like we're a tag team about to start a wrestling match, but you know, that's another subject. We're going to talk, I'm going to talk about APRs. We're going to have a little talk about low rectal cancers and the problem with low rectal cancers, the problem with APRs themselves. And then we're going to talk a bit about whether we have a choice or whether it's a necessity to do an APR. And then the different types of APR. Now we know about the different cylindrical APRs that we can do, but there's one or two other options that we may have. And then I'm going to touch upon tailor-made APRs. And the reason I'm only going to touch upon it is because I think you have to be very experienced surgically. The problem is we're being shown videos by surgeons that are very experienced, surgeons like, you know, Bill Heald, Amjad, Ayan Kazoo, and they make the difficult look easy. So we as surgeons just have to be careful and understand that some of these videos and some of these procedures are only suitable in certain hands. And at the end, I'll just try to show you an operative video that was taken while I was operating. I actually didn't know it was being taken, so it's literally off the cuff. So somebody described rectal cancer surgery once as a bit like taking a cork out of a bottle, and it pretty much is. You can see the mesorectum, and the mesorectum comes and it tapers down into the pelvis. And the surgeon, whether it's his open hand or whether it's a laparoscopic instrument, is trying to not necessarily push that way, but take the rectum out, and it's very difficult. So the anatomy is difficult. The mesorectum also attenuates close to the lower rectum, which makes it even more difficult to get margins in particular. We all know that the access is difficult, particularly in the male pelvis. And there's always a trade-off between organ preservation and oncology. And remember, this is the rectum in the pelvis, and there's other structures that go in and around between the cork and the neck of the bottle that we have to preserve, in other words, the nerves. This just shows what lots of series show, that the lower the cancer, the more likely we are to have a positive CRM rate. Now, let's just ignore the fact that in some series with the upper rectal cancers, they've got a positive rate of 16%. But the point is, the lower you get, the more likely you are to have a positive CRM. So in the 80s, there was a sea change in the way we treat rectal cancer surgery, and a paradigm shift after Bill Heald. Now, I'm not trying to embarrass, I'm sure Bill won't be embarrassed by this, but they say not all his superheroes wear capes. And really what Bill did was heroic, and the legacy he's left is just phenomenal. And he introduced the concept of the holy plane. And the holy plane is an anatomical embryological plane. And he suggested, particularly for the mid to lower rectal cancers, that we excise the mesorectum completely to the pelvic floor. I've underlined sharp dissection here because that's exactly the videos we've shown today are all sharp dissection, whether it's with hook diathermy, whether it's with a finger switch diathermy that was very elegantly shown by Bill Heald. But the point is, the good surgeons are dissecting sharp. And I say this because sometimes we see some videos, particularly I see some robotic videos of people doing rectal cancer surgery, and it's anything but sharp dissection. They may well be in the plane, but they're sort of levering the rectum forward or levering the rectum to the side and hoping that the separation is in the plane. I remember a time I trained with surgeons who are open surgeons, and there was a time where they put the hand in the pelvis and then they'll feel what they call the lateral ligaments. They'd call for the Moynihan forceps from the scrub nerve and put in 2 Moynihans on and cut between the two and saying those are the lateral ligaments. But actually, as Bill said earlier, that was the neurovascular bundle. So we understand now that there are no lateral ligaments. And you know, why is it important if you've got a positive CRM? Because of course that's related to local recurrence, which of course affects your outcome and your longevity of survival. We're quite lucky to be practicing in the era that we're practicing now, because we've had lots of modern advances. And Amjad alluded to this earlier, that this isn't just about survival, it's about quality of life. And so a lot of the modern advances that we've had help us preserve the sphincter and therefore give the patient a quality of life, we hope. We have laparoscopic stapling devices which angulate and articulate so we can go deep down into the pelvis. We have stapling devices that allow us to perform intracorporeal anastomosis really quite low, rather than the open technique of parachuting an anastomosis down, which was technically challenging and time consuming. We have local excision techniques, whether it's microsurgery or what have you. And of course, we have neoadjuvant strategies to help the surgeon to make surgery more successful in the form of debulking or destaging the tumor. And all this has meant that although the rates are variable, the APR rates are reducing. But there's a problem with an APR, is that Bill's lovely TME surgery that he espouses, it's improved outcomes with anterior resections, but there's been no similar improvement with abdominal perineal resections, or historically there hadn't. So having an APR, you're more likely to have a positive CRM, which of course then means you're more likely to get a local recurrence, which of course ultimately results in a lesser survival. And can I show you the specimen? The specimen, the problem is the arrows are pointing here, which is what's known as the waist. It's narrowed. Now, arguably, you could say, well, actually, that's quite a good TME specimen there. The problem is the surgeon quite naturally has followed the TME plane, excuse me, where it naturally attenuates. But the problem is if there's a cancer there, we're actually coning in the wrong place. So that's always been the problem. The decision-making's been poor. Surgeons don't always make use of the team around them, and we'll talk about team working now. But you know, it's about using every tool at your disposal to make sure that surgery is successful. So we now employ neoadjuvant treatments and strategies in order to help us. There is no doubt that surgery was poorer for APRs. A lot of that was because it wasn't standardized, and most of the surgeons I've spoken before have spoken about standardization and how important standardization is. So the problem's been that you're more likely to have had a positive CRM rate, much more likely to get a local recurrence than an anterior section, and ultimately that affects your survival, which is the game changer. Again, it doesn't matter which series you look at, and if you ignore that some of the series have got quite high positive rates in low anterior sections, but the quid pro quo is that actually they all have a 2 to 3 times higher positivity rate, whichever the series for APRs. And again, you know, why is it important if you have a positive CRM? Well, look at this. If your CRM is positive, you're 30% chance likely to have a recurrence, whereas it's only 9% chance to have a local recurrence with negative CRM. And that affects your survival. If you've got a positive CRM and an APR, your survival is 38% from 72%, which is, you know, astonishing, really. Again, just showing the same thing, that your cancer-specific survival is affected with a positive CRM. So in AP resections, you've got a positive CRM, your cancer-free survival at 5 years is only 50%. In anterior sections is a bit better at 65, and that reaches statistical significance, but either way, it's not very good. So in order to address the sort of variation in surgery, the UK in 2010 introduced LOREC. Now, I don't know if the audience is familiar with LAPCO, but LAPCO was introduced in order to standardize laparoscopic surgery to ensure that no matter where in the country the patient met a surgeon, the surgeon was trained appropriately in laparoscopic surgery. And this really mirrored that. And this was set up by the National Cancer Action Team in England, in the United Kingdom. And the objectives were to train the team. And I'll say that again, it's to train the team, not just the surgeon. I always say that the surgeon is a link in a chain, and the chain is only as strong as the weakest link. So if your radiology is weak, or your oncology is weak, or your ward care after the surgery is weak, the surgeon is compromised. So this concentrated on teaching the whole team in the MDT, optimizing the operative technique, and hopefully improving outcomes, oncological outcomes. That was the plan. Workshops were set up for all the members of the colorectal MDT. For surgeons in particular, there were cadaveric workshops with surgical mentoring. And for the radiologist, again, Bill's alluded to this, that we are so dependent on the preoperative imaging as rectal cancer surgery, that MRI workshops are set up for radiologists. And the effect of LOREC has been to halve the use of neoadjuvant treatment, which of course is associated with a lot of morbidity, but also it's very expensive in an economical sense. And it's virtually eradicated the use of short course radiotherapy. So just, you know, team working. I always say that surgery is all about the team. It's not just about the surgeon. And I'd argue that the MDT should function like an F1 team. I'm hoping this isn't going to be too loud for you. I'll play this. It's not a very long clip, but you'll get the idea. So I'm hoping you can hear me over the audio. And so the surgeon's not there yet, but this is the preoperative team. Whether it's the radiologist, whether it's the pre-op assessment, where it's the anesthetist, it's all preparing for a good outcome. And we all want the good outcome in the patient. So here we go. Here's the surgeon with the patient. The whole team is working in unison. So I don't know if you noticed that, but that was probably about 2 or 3 seconds, and the whole team has changed all 4 tires on that Formula One car. So, you know, teamwork, that's what it's all about. Now, the main title of the talk was about choice and necessity. Now, we can all make a choice, but one hopes that you make an informed choice. If you just make a random choice here, you look and you say, these are all pencils. Okay, I can take any one. But if you make an informed choice, you look and say, well, actually, that pencil's broken. There's a few which the stubs are very low, but there's one that stands out, which is sharp, and that's probably the best pencil. So you've made an informed choice. However, sometimes we do have no choice. And if that's the only tap of water in your village, then that's the only tap of water in the village. So that becomes a necessity. Justifications for doing an APR. When is it a necessity? Well, mostly it's about tumor characteristics. If you've got a locally advanced tumor involving surrogate or surrounding structures, if there's been a failure of neoadjuvant strategies, or patient factors, you might have a patient who doesn't want, and maybe incontinent perhaps, or has had sphincter damage from previous birthing injuries. To join somebody together with those sorts of factors would be probably unwise, and so therefore you might decide to do a prophylactic APR. I'll put down surgeon's experience as well. This is slightly controversial, but you know, if you ignore patient outcomes, it's probably an easier operation for a surgeon to do an APR than it is to do a good TME with an intracorporeal anastomosis and a defunctioning joint. But again, as I say, that's slightly controversial. And of course, there may be choice. The patient or the surgeon might choose to do the APR instead of a restorative surgery. So we're lucky to be living in the area that we're living in. There was an era where there was no choice and APRs were a necessity. So this, I'm sure you're all aware, is Ernest Miles, and he lived in an era, probably in an era before chemoradiotherapy. So if somebody had a cancer, they came to surgery. That was it, no choice. But just reading about him, I was interested to read that, you know, he was described as a master ambidextrous surgeon. He was brilliant and ambidextrous, which means very good with his hand, craftsman. His obituary noted that he's a legendary manual dexterity, or he had legendary manual dexterity. Gallagher witnessed some of the surgery by Miles, and he described an APR by Miles as one of the sights of London surgery in the 20s and 30s. This is the phenomenal bit. He would complete the abdominal phase in 40 minutes, and the perineal phase would be finished in 6 to 7 minutes. Now, I don't know about you, but I can't even do a hemorrhoidectomy in 6 to 7 minutes, let alone a bottom end. But anyway, despite this, he had very good results, and the mortality and recurrence reduced from 50 to 18%. So huge improvement in rectal cancer surgery. So again, we're lucky to be living in the times that we're living in. There have been a number of medical advances that have increased our choice to perform restorative surgery. So we can do minimally invasive surgery, which means we can get really low down into the pelvis, probably with much better views than some open surgeons would have. I'm obviously excluding Bill and Ayun and Amjad from those sorts of conversations. We have chemoradiotherapy that help downstage tumors so that we're more likely to be able to take the cancer out without worrying about positive margins. And not only that, we now have a subgroup of watch and wait, where who would have thought that giving chemoradiotherapy could bring about a complete response. And there's a 2/3 chance, a 60% chance that response is maintained and the patient is served from what ultimately is very mutilating surgery. I think we'll all agree, no matter how neatly it's done, it's still very mutilating. The surgical advances have helped us. And the surgical advances are such that, you know, the scales are now weighed heavily in favor of sphincter preservation. And really, the only reason to do a permanent colostomy is patient or tumor factors. Sphincter preservation has been aided by technological advances. So we have stapling devices, let's say articulated stapling devices, and they help us get really low down in the pelvis, certainly laparoscopically, but even in open surgery. Laparoscopic surgery, we have a magnified view. Your eye is on the end of the laparoscope. I know Bill shows us very good views, but ultimately the eye is in the surgeon's head. And if you're an open surgeon, there's only so far down you can see. And the beauty about laparoscopic surgery is that your lens or your eye is on the end of a laparoscope, and that can go anywhere you want into the pelvis, as low as you want. So you've got views at the very least. And then robotics also, one would argue, is a game changer, because now we don't just have straight instruments to do the operating. we have articulated instruments and high definition 3D view, albeit without any haptic feedback. But sometimes, despite all that, there is still no choice. And I've spoken about there may be tumor factors and other factors affecting why we do an APE, but these mean that we may not have a choice and we still have to do an APR. Bill would suggest that less than 10% of, or I should say, a surgeon's rate of APR should be less than 10%. But it's fair to say that the rates are very variable, and some historically have been very high. So let's just look at a conventional APR, and this is the diagram I showed you earlier. Again, if you just ignore this part of the specimen, you would say that that's quite a nice TME specimen. It's following the mesorectal plane. It appears to be shiny, but actually, if you could look through there and see that there was a cancer there, then you can see that we've actually coned in the wrong place and put at risk, or put the patient at risk of having a positive margin, or worse, even having a local perforation, and the patient then immediately becomes palliative. So that's what we mean by a wasted specimen. There's a waste on the specimen because the surgeon's coned in, because the surgeon's eye wants to follow the TME, and that's historically what the AP has been. Also, it's not standardized. So again, very great variability in how people perform this. And as I say, the results are variable because of the perforations and the positive margins. So changing concepts in the recent past of APEs, there are three real varieties, and we'll go through these in the next few slides. Intersphincteric, ischioanal, and the cylindrical extralevator described by Torben Holmes. Whichever technique's done, it should be a standardized technique. I remember being a trainee, and as a trainee, it's very frustrating watching the same surgeon doing the same operation differently every time. To see a surgeon to do the same operation in methodically the same way, if you look at some of Amjad's videos and Bill Heald's videos and Ayaan Kazu's videos, you could say that they're almost carbon copies of each other, because actually they follow a very standardized approach. And having a standardized approach just improves quality. But this is very important. We're so reliant on accurate preoperative imaging, whether it's with an MRI scan, whether it's an ultrasound, endoanal ultrasound scan, but never forget clinical assessment. The digital rectal examination is also an important tool in preoperative assessment. So intersphincteric APE. Now, if you have a look at this diagram, there's a cancer here, and yes, we can probably follow the TME to here, and we can apply a staple line here. That's probably as low as we can get. So if you see, there's only so low you can get, probably to the top of the sphincters. But if the cancer's at that level, your staple line is going to be without a margin from the cancer, or worse, it could involve the cancer, which would be a disaster. So for those reasons, an intersphincteric may be an option. There's no point doing a conventional APR, because actually we don't need a wide margin. It's really just for technicalities that an intersphincteric would be suitable. So you follow the intersphincteric plane and then join the mesorectal plane here. Now, what this does is it accounts for the fact there's no space for the stapler. You've got your buffer around the cancer, so that's fine. And it also avoids a large perineal defect that you'd get with a traditional conventional APR. There is another choice, and I say this guardedly, and that's an APR, coloanal join. So if you were to imagine that you did your cross section here above the tumor, then you can actually anastomose there down to the coloanal area. It's possible. I have to say, in my hands, the functional outcomes are variable, but it's certainly possible. However, you may have to ignore the fact that you can do a coloanal join, because it becomes a necessity if the patient's got a history of incontinence. If the patient's got lots of comorbidities, then it may be more convenient to just do the APR. And of course, it may be the patient's preference. Now, you say, why would the patient have a preference for an APR? There are some patients, again, in my experiences, they're very professional, that want control in their lives. It's quite convenient for them to have a stoma rather than to have variable bowel function. But again, that's a point for discussion. That's just an observation. So the second type is the ischianal APE. Now here really we don't have a choice because you've got a locally advanced tumour. It's fistulating through the sphincters, perhaps into the ischianal fat. And so the only option we've got is a wide resection margin into the ischianal fossa. And of course, this defect would be nigh on impossible to close primarily, and so requires plastic surgical flaps. And as I say, this is for locally advanced cancers. So Torben Holmes, let's talk about the extralevator cylindrical APE. The principles are exactly that described by Miles and Bill, in that it's TME surgery, but there comes a point where you stop. You don't follow the TME plane in as it cones into the lower end. You actually stop at the pelvic floor. And the principle of this surgery is to take the specimen en bloc with the levators and the sphincters. So actually, if you look at traditional conventional APEs, they often go out here. There's no oncological benefit in a wider margin here. So en bloc, sphincter and levator with the mesorectum without going into this plane and coning in and towards the cancer. And that hopefully reduces the chance of bowel perforation and reduces your chance of CRM positivity. I hope this comes across well. I'll show you this video in a second. How do we do an extralevator APE? Well, the anus is closed with a purse string. I have to say that a lot of surgeons very reasonably use the Lone Star retractor. I find the Lone Star retractor very fiddly, and I think in my hands it gets in my ways. And the barbs are very sharp on the retractor itself, so therefore I prefer just using simple silk stitches, which I'm sorry if it looks a bit gruesome, but compared to what we're doing, hopefully it's not too uncomfortable for the patient. But what this has also done, because the perineum is often very shallow, it flattens the perineum for surgery as well. So the dissection is outside the subcutaneous part of the external anal sphincter, and I'll go through this on the video. We then find the levators and follow the levators out to the pelvic sidewall to their insertion. Remember that all the ischianal fat is left behind here. This video shows that I've disarticulated the coccyx here, and that darkness there is joining the top end that I've done. This was probably laparoscopic, I think. And you can see the air there from the top end. So we've disarticulated the coccyx. Again, some would say that do you need to disarticulate the coccyx? Honestly, in my hands, I worry about traumatizing the specimen, taking it out through the bottom end if it's not disarticulated. I suppose you could argue not in a female, but certainly in a male, I would disarticulate the coccyx. And then you evert the specimen, and then you've dissected off the prostate of the vagina, obviously depending on the patient. The beauty about this procedure, the bottom end is done prone jackknife, which as a surgeon is very comfortable. You can stand between the legs if you like, or to one side, and you've got room for your assistants. If you do get some bleeding, the blood goes away from you, but hopefully, you limit that because your views are very good. And that's exactly as I described, that, you can then do the extralevator APE in a much more comfortable way. I trained in an area where I helped surgeons do AP resections, and it was just a bloodbath, firstly. Secondly, it was very difficult to assist because the patient was often in extreme lithotomy positions, and it's very difficult to get one head, let alone two or three heads, to see what the operating surgeon is doing. And Torben Holmes and his group showed that actually adopting the extralevator APE, the cylindrical APE, that there's very acceptable or reduces the perforation and the CRM positivity rates and the local recurrence rates. This is a caveat that I add. We're talking about choice or necessity. Do we have to do an extra levator APE? If I go back to this diagram, if I can go back to this diagram. Now, if the tumor is here, okay, we need to take the sphincters here, but you could argue, is there any benefit in taking the same approach or going wide in the opposite side of the tumor? Now, I use that argument guardedly. I think in the right hands with the right decision making, then maybe, but starting out, I would certainly not be advocating a tailored APR. I think Amjad showed a picture of his tailored APR, and if you want to see the video, it's on YouTube. Hopefully you've got these slides, and that reference is on the slides. So I'm hoping that you can see these videos now. So I wasn't aware that this was being videoed because the video camera is actually in the light source, in the overhead light. And so one of the fellows, Chaitanya, just decided to video. And so at times there's heads getting in the way, but anyway, I'll try to describe. So as you can see, there's a purse string closure of the anus. I've used my retracting stitches. I do them at 2, 6, and 5 o'clock, and then mirrored on the other side. And this is called a teardrop incision. Again, if I knew they were videoing, I would have showed the top of the teardrop, but it comes from the coccyx down. Now, nature has helped us because generally the pigmented part of the perineum is where the sphincters are. So if you go outside the pigmented part, inevitably and invariably you will incorporate the sphincters. Now, this is a very sped up film. I have to say it's still not 7 minutes sped up, but that's another matter. But you can say it's about being methodical. A lot of the videos you've seen, it's not about speed. Speed is trauma. It's about, views. It's about seeing the planes that you're operating in. But again, you can see if there's bleeding, the blood goes away from you, but you can control the bleeding as you go along. It's traction and counter traction. You've heard that word used before. And circumferentially, I go around and go through the dermis to get to the fat. Oops, that was a mistake. So there we go. I've now gone all the way around. And as you can see, I'm now finding, hopefully you can see from the video, that I found the plane between the ischioanal fat and the external sphincter. Now remember, the external sphincter is it's a voluntary sphincter, so it's skeletal muscle, and skeletal muscle is red. So with traction and counter traction, hopefully we can see the plane between the two there. So you can see my hand is retracting the muscle to the left, and the assistant's hand is retracting the ischioanal fat to the right, and the opposite side is true as well. So there's the ellipse of skin. I'm trying hard not to go down too far on one side to complete the dissection circumferentially. One point I should make, particularly in male patients, is often I use a largish elastic catheter because you want to be able to feel the urethra and know that you're clear of the urethra. The difficult dissection always in my hands is anteriorly in males particularly. But here you can see we're following the sphincter, external sphincter down. Again, sorry about the heads, but external sphincter, ischioanal fat. I've now got a Lane's forceps on the specimen, and that's the ellipse of skin there. And we're trying to find where the levators are. So we're going to follow the sphincters down to the levators, and then we're going to follow the levators out to the pelvic side wall. Okay, so you get the idea there. So in the interest of time, I'll just speed up a bit because I'm probably overrunning a bit. But the next step is that I'd like to disarticulate the coccyx. So if I just go forward a bit, I'm hoping this will work. So there at the top, you can just see I have a coccus on the coccyx at the top here. I'm sorry if the view's not brilliant, but I've just disarticulated the coccyx, and I'm going through Waldeye's fascia to try to join my dissection on the inside. Okay. So again, I'll forward that a bit in as well. Now, often I'll pause it there. When I've done the top end, I leave a swab in the top end so that I've got something to aim for from the bottom. So now I'm looking for the swab. And you'll see, hopefully in a minute, that I'll get the sponge forceps there. There's the swab coming out from the top end there. And hopefully you saw it wasn't too red. Now that's an important thing, that, I've taken the dissection on the levators out laterally. I've got a finger above and the thumb below, and then you can complete your dissection by disconnecting the levators from the point of insertion, but the levators are taken en bloc with the specimen. Okay. So again, just fast forward in the interest of time. I'm sorry to say. I'm not a quick surgeon. So there, I'm using an energy device now to disconnect the levators from the point of insertion. And there, I'll just go back. Hopefully you saw that I then everted the specimen. So the specimen can now be everted there. I hope you saw that. And now we're into the pelvis. True, what I've done before I inverted the specimen was to make a good angle of attack, a lot of space in order to evert the specimen. And so now we can carry on with the dissection. Apologies about that. I think I heard a phone call there. Again, this isn't an edited video, and hopefully you can see that it's not a bloodbath. It's all done in a very, controlled. My apologies, a very controlled way, in order to get a good outcome. Sorry, I'm being distracted by telephone calls here. But you get to the point where you can actually take the specimen out, and the specimen has now come out. And I'm just going to show you somewhere here. The specimen's out there, so you can see there's the back wall of the vagina. There's a swab on it. The swab's not very red; it's still quite white, and there's not a huge defect here. So hopefully that's showing you that the strategies and the standardized way in which we try to do the cylindrical APR. And again, sorry, I lost my train of thought because I've had a couple of phone calls while I've been talking, but that's the dangers of doing a presentation from home. You have children running around and phone calls, but never mind. The defect, this is a biological mesh. I use a biological mesh. Now, actually, I've changed the mesh that I used. This was something called a Cook Biodesign mesh. And after a couple of cases, the rep came to see us and said, this is a very good mesh and very good for this particular technique. But a couple of cases I noticed were getting perineal hernias. And when you scan them, you saw that the mesh was fractured. And then the rep admitted that actually these meshes weren't suitable to bridge a gap. They were only suitable to reinforce a gap. So we've now changed to Permacol meshes. I'm sure you're familiar with Permacol. There, so that's just stitching the mesh in, closing the defect. There'll come a point where I'll release these sutures. There's no tension on my closure. Again, in interest time, I'll just speed this up. There, and then you got closure and layers. Again, no tension. The sutures have been cut out so that perineum falls together again. And as I say, we're just bringing together the wound closure in layers. This is one of the early ones that I did, and that's a Robinson's drain. I use Redivac drains now, suction drains, and I leave the suction on for 48 hours, then off suction for 24 hours, and then take the drain out at 72 hours. That's what I tend to do. Okay, sorry about the distractions and sorry about the slightly disjointed presentation of the video. But hopefully you get the idea. This wasn't an edited video. I fast forward the same video, and hopefully you see that actually there was no bleeding or no significant bleeding, but the views are very good, and you can see planes if you try hard. Okay, that's the end of my presentation, I think. Thank you very much again for everybody, and I look forward to any questions.
Thank you very much, Taz. As always, nice, thorough presentation. And I'm sure, Rustam, have you got any questions from the audience for Professor Qureshi?
Yes, we have a question from chat. Is prone position the best choice for APR? Standard APR and extra elevator APR. Maybe your choice change if you do standard APR.
I don't think it would, to be honest with you. I think the point I'm trying to make, there's a few reasons. Let's talk about the slightly softer reasons. That's the point of the operation. It's quite nice to have a 5-minute break as a surgeon, because often there's only one surgeon. And so while the patient's being turned, you have a bit of a time out as a surgeon. But what I hope to have shown you is that the views are unparalleled. What I don't have is the view of an APR. And I accept that we've got senior surgeons like Bill on the line, but my experience of APRs in the lithotomy position isn't very good as the surgeon, as the operating surgeon, and certainly not as the assistant, that the views aren't as good. Now, what I hope to have demonstrated in that video is that having the patient, Bill, you're trying to say something.
Well, I wouldn't butt in, but I'd say something when you finish, Taz.
Yeah, no, but please feel free. But what I was going to say was, what I hope to have shown is that having the patient prone jackknife is the views are just so much better. And it facilitates not just the surgical view, it facilitates the assistance. And ultimately what we're trying to do is we're trying to train a younger generation of surgeon, and the views are so much better prone jackknife. Bill, you were going to say something.
Well, I agree exactly with what you're saying, and I wanted to just add the weight of my experience is I was taught by Marek Bebenek in Wrocław, which is in Poland, and I went there to do TMEs. They wanted me to show them TMEs. We did 8 rectal cancers in 2 days, about 20 years ago this was. I had all my life done APE the way the British suggested. Lloyd Davis and Naunton Morgan had suggested what was called synchronous combined excision. And my eyes were opened. I wasn't really teaching Marek. Maybe I might have taught him a little bit about TME, but he totally changed my practice. And I abandoned the idea of synchronous combined excision with the patient on his or her back, and went to, when it was necessary, it was only 10% of my cases, as has been commented, as you commented. But I was so, of the 8 cases, Marek had decided to do 4 of them by APE and 4 of them by anterior resection. And in fact, I would have done 6 and 2. So it was a pretty representative group of substantial low rectal cancers. And I came away having learned that I could see the back of the prostate, the vesicles, and the area that's so difficult of the perineal body, as it's called, where there's no plane, and you are terribly close at the front to the urethra and terribly close at the back to the, I'm sorry, I'm talking upside down. You're terribly close to it as you're looking down. You're terribly close anteriorly to the urethra, which is at the bottom of your operation field, and at the proximal to you, and lifting the cancer back off the urethra. It's a very difficult dissection. And a part of it, which I think rather few people have really got their heads around, is identifying the neurovascular bundles. And I think I'd done another 50 of these face down before I really started to identify the neurovascular bundles. So this is for me, a completely separate talk, and I'm totally behind you. And I think we could cooperate in trying to teach some other people, because it's very attractive to a surgeon who likes planes to put the patient face down and to try to save their sexual function, because actually you can identify the neurovascular bundles and see them tapering into the root of the penis and so on. But I'm not sure what percentage of surgeons around the world have ever actually seen and identified those nerves in that position. And I don't think you can do it except from behind. Interestingly, the person who originally said that said it at the end of the 19th century, and his name was Theodore Cocker. And I've got a slide with his words on, which say that his actual words were, the dissection of the sacrococcygeal region low down is best done from behind. You could do it with the patient on the side, as some have done, or the patient on the face. And I do think it's something worth thinking about. It's not really caught on in a major way in England. You are caught on, obviously caught in this idea that you are happier. You're a surgeon who loves detail and planes and quality of specimen and nerve preservation. And if you love all these things, I think it is worth that turnover. And I agree with you, the cup of coffee the surgeon gets whilst they do it is very health-giving. Thanks. I'm sorry, that was almost a talk in itself.
No, thank you very much for those wise words, Bill. Jed, I think you need to be unmuted.
Rustam, have you got any further comments or questions before we finish the international session? Because I know that we have overrun and a lot of my Russian colleagues are probably waiting to speak.
Thank you. Thank you very much, Professor Qureshi.
Nice to see you again.
Thank you. And now we must do a short break for short video, and we will be back after 2 minutes. Okay?
Okay. I think this is the end of the international session. So if my colleagues wish to go.
No. We will be back later.
Okay.
Okay.
Okay. 2 minutes, 2-3 minutes.
Okay. Should we just say goodbye to everybody then, Amjad, if
yeah,
that's the end of the international?
2 minutes.
Yes. Yeah, you could be. I think they probably want
yes,
to
short break 2 minutes.
I think if you will forgive me, I will move on to my work because I have some other appointments. In fact, I'm talking remotely in Milan in a couple of hours, and I have to get ready for that and organize for that. So may I say goodbye, and what a privilege, and it's good to keep my Russian friends, at least sadly at rather a long arm's length, but I hope the goodwill and the desire to communicate is at least kept alive. Thank you very much for inviting me, Amjad.
Thank you,
and
Prof.
Tash, thank you very much too.
No, thank you, Bill. Thanks for your comments. Nice to see you. Looking well. Stay well, Bill.
I try.
Rustam, can I say thank you and goodbye as well? It's nice to see you. I'm sorry it's on a TV screen, and your friends and colleagues. And to all the organisers, thank you very much. It's running very smoothly, and certainly from my end, there's no problems with the audiovisual links. It's all going very well. So Rustam, thank you, and it's your turn to come to England.
Thank you.
Thanks, guys. Thank you
very good. Amjad, thanks very much.
Thank you very much. Thank you very much, dear professors, for your. It's a great pleasure for us to see you. Okay, thank you very much.
Bye-bye.
Okay, we made changes in our plan, and now let me to introduce next presenter. It is Ilya Chernikovsky with his friend Pavel Melnikov. Please.
Thank you, Rustam. Thank you very much. Good afternoon, dear colleagues. Very nice to be in the company of high-level professionals. And I'm now in my hometown in St. Petersburg, somewhere not far from Alexei Karachun. I'm grateful to them for the opportunity to be among you. In my opinion, Rustam's team is one of the just today, one of the residents of our Pavlenko surgical performed in Ufa his first sigmoidectomy with this lymph node dissection. Congrats. And my congrats to Rustam and Dmitry. I speak about our surgical resident. And I will give the floor to my colleague and co-speaker, Pavel Melnikov.
Hello, everyone. I hope everyone is hearing me. And my name is Melnikov Pavel. I'm representing colorectal department of Moscow Cancer Center number 62, as well as Dr. Ilya Chernikovsky, my speaker. I'm sitting in his office right now, fortunately. And we will talk about problems in surgical education in Russia and its related challenges and solutions. So let's start with the introduction. You all know that after the fall of the Soviet Union, there were a lot of problems in economical sphere, in social sphere, as well as in healthcare and educational area. Our authorities and government try to do all the best as they understand to improve the situation. But we are, as a part of professional community, still see a lot of weak points in this field. First of all, our education more and more becomes not free of charge. There are a lot of university centers with old infrastructure, not enough experienced mentors and motivated instructors, a lot of issues in juridical regulation, and unfortunately, we don't have one objective assessment of learning. And finally, this presentation, we want to share with you our project. How could we influence on improving this situation? First of all, let's start with paid education. For example, the cost of the training in surgical oncology residency reaches $500,000 rubles for 2 years, and it's dramatically becoming a problem because our country is middle-income country, and it becomes a barrier for young and talented students to go into the surgical residentship. Because after they graduate the training, their median salary is near 50,000 rubles per month. So that is the first problem. It's become a problem because in the time of economical crisis, the problem become bigger and bigger. The second one, but I suppose that it's the major problem. We have old educational infrastructure, and this is like catastrophe. I want to share with you some examples. This is didactic material, educational material for fellowship and for residency, for management of rectal cancer. And it's written here that for evaluation of the patient with rectal cancer, you need just a digital rectal examination, barium enema, rectal mammoscopy with biopsy for cytology, and ultrasound. And in some selected cases, you could use CT scan for evaluation for liver metastasis. So everyone of us understand that it's the dramatic, catastrophic, poor knowledge for the residents. The next example, this is a guideline for the students. And first of all, let's look at the literature references. They came to us from the middle of 50s, 60s, 70s, 80s, and maybe that's why it's written here that chemotherapy in case of gastric cancer is not effective, and you could use it only with palliative intent. The majority of the patients should have surgical treatment. They suppose that 4th stage of gastric cancer, it's a bulky tumor. So all of you understand that is fully incorrectly understanding of this disorder. I want to name this slide expectation and reality. Unfortunately, the photo from the right, you can find in a single centers throughout Russia. So we don't have enough opportunities to give the modern training for our residents and students. And the majority of the centers has the situation that you could observe on the photo on the left. One of the biggest problems in Russia is juridical dysregulation, because it is a fact that residents in Russia can do their surgical procedure by their own. And the chief oncologist of Moscow, Professor Khatькov, claims that young surgeons cannot do surgery on their own to be independent surgeon at the end of the training. But even in the new draft order, the rights and obligations are not specified for the young surgeons and residents. And it's another big problem. Objective assessment of learning. The next problem that we will discuss, our nation model, it's cognitive proctoring, in which quality assessment is very hard and there is no objective criteria. But we have Western model with its simulation programs and objective testing. And we know that Richard Resnick and Jennifer Martin in the middle of 19th proposed their own approach, which called ASATS, Objective Structured Assessment of Technical Skills, which well implemented in different countries and systems. What do I mean when I say ASATS? You could divide every surgical procedure on the stages, and every stage of this procedure you could assess in one point. So the overall, when you summarize this score, you could understand, does the trainee fail the test or he could pass the test? And if we look at this paper by Danilo Mishkevich, he implement this tool in training for laparoscopic colorectal surgery in Great Britain. He divided the same surgical procedure in different steps. And after that, he assessed every trainee. There were near 300 trainees and a little more than 300 mentors with 600 assessments. And in summary, he could divide different levels of different steps of the procedures by the complexity. Another necessary tool in assessment of training is assessment of video of the surgery. We use video assessment in different areas, for example, in sport, and we all know that it's well implemented in the LABCA program in Great Britain. You can form your decision making about the readiness of the transition to the next stage. It is always blind and independent assessment. You could use a SAT score that we talked previously. It is proven that better scores correlates with improving clinical results, and you could use artificial intelligence as an assessment tool. Unfortunately, video assessment has their own limitation. You could see only operation field. You can't hear conversation between the surgical team. You don't have the data of the patient. There is no one gold rule for video editing, and the trainee could edit the video by himself. And there is a problem of data storage safety. How could we assess video? First of all, yes, of course, it is self-assessment, but also you could use surgeon expert assessment. You can use crowdsourcing that proven to correlate with expert opinion, and you could use artificial intelligence. So let's talk about safety of assessment by surgeon experts. In this paper, there were 4 pairs of experts evaluated the video of the surgery. It was low anterior resection and Nissen fundoplication. And it turned out that 3 out of 4 pairs have same ratings. Conclusion, this approach is an objective assessment approach. Another method for video assessment is crowdsourcing. We find out one paper in which there were 3 group of assessors. First one was from Amazon Mechanical Turk. Second one was from were Facebook users, and third group were surgeons experts in robotic surgery. And it was found out that full correlation between 10 verified expert surgeons and assessment in a Facebook or Amazon. But the benefit was that the assessment on Amazon was faster. Video was evaluated, video assessed by Amazon group was for 5 days, and surgeons expert assessed the video in 24 days. So another big division in modern healthcare, it is artificial intelligence that gives you more and more opportunities to assess the video of surgeons. You can use machine learning is the biggest part of artificial intelligence. It gives you a high precision to divide the video of surgery by the expert surgeon, and for the beginning with precision more than 85%. You can use natural language processing and computer vision for detecting sequences of the surgical steps with a high sensitivity. So in the future, it could give us the opportunity for intraoperative support in decision making. There are a lot of different approaches for training of the surgeons, but we want to share with you our project, which called School of Practical Oncology, named after Andrei Pavlenko. So as we all know, the better surgeon, the better hospital, then the better treatment we could give to the patient. And we could improve the chance for survival always 2 times, depending on different hospitals and surgeons. So if we look at the data for colorectal cancer, we could add additional 25% in survival, and depending on different hospitals and surgeons. And if you look on the photo on the right, you could see the differences between results in treatment for lung cancer between Russia and the United States. And that means that the effectiveness of treatment in Russia could be much better. So what are our basic principles? It's 7 steps, and we use system of mentoring, 1 mentor and 2 residents. And I know that in UFA, we have also our filial of practical school of oncology, and Dmitry and Rustem also involved in this program. We have educational models integrated in practice, different rotation system, including international training program. We have system of selection and quality control, independent audit, and here I see Amjad Pravais, who is also involved in audit assessment. And also, you know, this is a program for the future, because we want to make a register for graduates and then monitor their professional activities. So we want to do our community with the best members in surgical society. Also, we don't learn the basic surgical skill. It's our rule. Unfortunately, residents are not involved in the clinical and research work, and so on. We have 2 stages for admission to our program. First stage, it is correspondence stage, where resident should give some CV and some information about himself. We assess him, his theoretical knowledge, and finally, we assess his surgical video, any type of the procedure that he could do. And the second stage, it is interview in person, but generally interview with the mentor. This year we have our first class, and their major is colorectal cancer. It is located on the 4 hospitals, and they started their education this September. They have different educational blocks for first year of education. It's not about these blocks not only dedicated due to the colorectal cancer, but also clinical communication, leadership, evidence-based medicine, and so on, that we suppose it's very necessary to build a modern surgeon. But every year, every month, they teach some step of the procedure. For example, introduction of workers, exposure, dissection, mobilization, and so on. And after 3 months of indication, mentors assess them by their video. That's all. Also sign in for our project for Surgeons Club. This is another educational tool for all Russian-speaking surgeons throughout the world, sometimes English-speaking. But anyway, this is our presentation and our point of view on the weak point of surgical training. Thank you very much. If you have some questions, feel free yourself. Ask me, Elia. Thank you.
Thank you very much, Ilya. Thank you, Pavel, for your presentation. And let me to introduce next presenter, Alexey Petrov, and his presentation. Please, Alexey, do you hear us? Thank you. Okay. Alexey, are you ready? Do you hear us, Alexey?
Все было бы неплохо, но вы, Алексей Сергеевич, звук отключили. Если вы включите звук, организатор Алексей Сергеевич, он подключится.
Ребят, включите звук.
Да,
Алексей,
здравствуйте.
Please.
Okay, hello everyone. I hope you can hear me and see the screen. Is that correct? So today we'll be talking about D2 and D3 lymphadenectomy, and I was very happy to be able to hear a part of the first talk on CME as well. And I think my talk will be in a certain way about the same thing, but from a completely different point of view, as I think. So when we're considering this talk about D2 and D3, it's really a huge topic, not for 15 minutes, of course. So we're trying to analyze and to think about two main aspects, actually. When we're talking about D2 and D3, it goes for any topic, actually. We are to think what we will talk about, and not less important that we are to know what we will not talk about. And I will start with probably an unusual thing and say that we won't be talking about CME. This concept is very nicely described from one aspect, from the aspect of layers, and it was mentioned today several times that this is short dissection of fascia layers resulting in specimen covered from both sides by the fascia. And also it was mentioned that there was a pathology study showing that this approach gives the survival benefit. And I would like to underline here that the survival benefit was connected with the integrity of the fascia. So when we're talking about the layer of the dissection, CME is a perfect concept. It is proven, and there are no questions whatsoever about the layers. On the other hand, when we're talking about CME, there is a certain confusion with nodes. Because even today in the morning, we've heard about CME with retropancreatic node. There is a concept of CME with central vascular ligation. And from the language point of view, if we think about that, you can imagine tea with milk because there is tea without milk. That makes sense. You cannot think about cappuccino with milk because there is no cappuccino without milk. Therefore, if we're saying, and if we're agreeing with the concept of CME with central vascular ligation, we should admit that there is a possibility of CME without central vascular ligation. Therefore, for us, and we think that this approach to terminology is very precise and useful among surgeons. When we're using concept of CME, we're talking just about the layers because the level of vessel transection and lymph node dissection is a bit of a gray area because one of the concepts of CME, one of the articles on CME with CVL again, proclaimed that vessels may be ligated up to 1 centimeter away from their origin. And this is still CVL or CME, what that surgery is, because if you think about difference between D2 and D3, this 1 centimeter may be crucial. So we'll leave CME aside and we'll just use it for description for layers. Another thing that we won't be describing and won't be talking about today is proximal and distal clearance. There are several Japanese studies on the lateral spread of lymph node metastasis. One, I think, goes back to 1986, and the other was last year. And they show very clearly that the risk of metastasis further than 10 centimeters along the colon from the tumor in the paracolic lymph node is less than 0.02%. So from that perspective, we just take the ruler in the operating room, put it to the tumor, measure 10 centimeters, and get our transection point. There is some confusion, again, with D2, D3, CVL, CME. Some people think that you ought to take middle colics for any tumor location. In our view, lateral spread is something independent, and we just use 10 centimeter rule. And for us, that's enough. We find the vessels that relate to this region, and we transect them. So today we will be talking about this green area, this vertical lymph node dissection, whether it's D2, D3, or further. And this is a Japanese concept, we all know that, and probably we should go to the origin and pay attention to how our Japanese colleagues are describing that. So to begin with, at the moment, in their latest guidelines, D3 is recommended for all tumors invading through muscular atrophy. This recommendation is coming actually from experience, as by now there is no randomized trials comparing D2 and D3 published with long-term outcomes. So they were just doing that, and they continued doing that after the guideline. What is the most important thing for us, I think, is the landmark that was used when D2 and D3 were defined and were introduced. And again, we should address our Japanese colleagues to get to the origin of this. So very useful thing everybody knows that is the Japanese classification of lymph nodes, almost of everything, but of colon. Each station has its number, each region has its number, they're coded, D1 nodes and with 1, D2 nodes and with 2, D3 nodes, which we're talking about now, and with 3. And these are the nodes that we're talking about at the moment. The most important thing, and probably if there is one thing that I would like to be remembered after this talk, is this picture of the map. This is the northern region of our planet, and this blue line is the polar circle. And I traveled last summer by car from St. Petersburg to Murmansk, and I was going through this region through polar circle, and I could be surprised, but there is no line outside the map. So there is no line on the road, in the forest, in the field, anywhere besides the map. So the same goes for lymph node dissection. These lines that are defining our borders of the dissection, they're only in our minds and in our pictures. So therefore, it is crucial to draw them in the correct place. And to find out what place is correct for D3 determination, we should go back to Japanese studies. And unlike some people say, there is nothing about landmarks in English language version of guidelines. But if we go further to their description of clinical trial comparing open and lap D3 dissection for right colon, we can see the landmark there. And the landmark that surgeons were using, that researchers were using, is the vein. This is the article that I'm talking about. And in the part of methods, it is mentioned that for right-sided lesions, vascular pedicles were clipped and dissected at their origin with removal of draining lymphatic system at the anterior surface of the superior mesenteric vein. Some people say, well, lymph nodes, it's always arteries. Actually, if you go back to the most important picture of this talk of the map, it doesn't really matter, because metastases don't care, lymph nodes don't care, lymphatic cells don't care where the border is. The only requirement, the only thing that we are to have is the agreement on this line. And I think it makes sense to draw the line of D3 lymph node dissection exactly like Japanese surgeons who introduced this technique used. So for right side is the vein, for left side is the anterior surface of the aorta. But obviously, I didn't stop at the polar circle. I went further to Murmansk, and obviously we can go further than D3, but we are to call it further than D3. So D1 is paracolic level, D2 is intermediate in the root of the mesentery, D3 is along the vein or along the aorta, and there is surgery beyond D3, of course, but for easy understanding, we are to call it the same way. So this is a very ancient article from 1990s. You can see black and white picture. Everything is mobilized under the pancreas, above the pancreas, 6 stations. There are certain articles over the last years, in 2020 even, but if you pay attention to the names of the articles, usually they're called beyond D3, extended D3, we call them D3 plus, whatever. But we are to keep in mind that if we're using Japanese classification, at the moment that we're further than the anterior surface of the vein, we're beyond D3. It's not probably a bad procedure. I'm not saying anything against it, but it's just different. And for now, the data that we have is only coming from non-randomized trials. It says only about safety and feasibility, 4 to 6% of lymph node metastasis in D3 and beyond. Maybe I failed, but I couldn't find any study that was examining D3 and beyond D3 stations separately. No data, therefore, is published about the beyond D3 collector. No evidence so far of survival benefit, and all researchers proclaim that these metastases are signs of poor prognosis. But so far, in our center, we do not find any indications to use this data as the force to change our practice, and we not do beyond D3 in routine practice. So if we're coming back just to our topic, comparing D2 and D3, what we have for today. So we have numerous non-randomized studies saying that this is safe and feasible. We have several studies showing from 5 to 10% metastasis in D3 nodes and potential survival benefit. I would like to stop a little bit on the third bullet point. Again, there are different views on this. Some people would say that, well, there are 5% or 10% metastasis, we are to go for this node. But I'm pretty sure that if you go beyond D3, you will have 4 to 9. If you go to subclavial nodes, you will have 1 to 2% metastasis there. So the number itself for us is not an indication to extend lymph node dissection. The only thing we're waiting for is the survival data, which is yet to come. Now, surgeons are very active in researching these D2 and D3. There are several randomized trials, but one of the problems in the trial is that the only way you can audit the dissection that was performed is intraoperative imaging. Because as for CME quality or TME quality, you can send it to blinded pathologist and he will tell you if the fascia is okay or there is a tear or anything. If we're talking about the pedicle and the landmarks, all the landmarks relate to structures that are staying in the patient. We're not removing mesenteric vein, obviously. So just judging by the clip, your pathologist won't be able to tell which dissection was performed. So this is a technical challenge that we are to overcome conducting trials, because we have to audit the dissection that was really performed. There are several randomized trials. We will not stop on each of them. I just want to show you that even the names and even the groups in these studies show that there is a complete mess in terminology, because some studies will compare CME with D3, opposing these two techniques, which are the same for some surgeons. Some will compare D2 with CME. Again, does it make any sense, really? Others will compare conventional surgery, which is a very mysterious thing, and it is not described in their protocol and clinical trials, with CME, with CVL. So there is a complete mess of the CME, D2, D3, and everything. Therefore, we're offering for last several years to divide this and to leave CME for layers, like we have TME. Nobody says where you're taking IMA when you're doing TME in the pelvis. Why should it be any different for colon? So, and there was a letter by Royal Holmes, I think, to colorectal disease, offering pretty much the same thing, to call procedures CME with D2 or CME with D3. If you were going along the layer and did certain lymph node dissection, that makes sense for us. The only trial which is published is the LCME trial. Their primary endpoint was lymph node harvest. They didn't show any differences between D2 and D3 groups. No long-term data is available. As probably you know, we're conducting cold trial. We have just 20 patients to enroll to finish enrollment of 668 patients, which was a huge effort for us. And I'm very grateful for all the centers and for all people involved. It's teamwork. If you remember the movie about the Ferrari, there are much more people involved in our trial. So for now, the thing that we can say for sure is that we're capable of much more things that we think we are capable of. So we've managed to almost enroll every patient we wanted. We've managed to publish in BGS Open and BGS, which is also a very new thing for Russian surgeons. And what can we say about first 100 patients? Don't be surprised that enrollment is almost over, but only 100 patients analyzed. This is due to very challenging monitoring process and the data analysis. It is very complicated, so it is coming with certain delay. Complications were the same. You might be surprised by a high number, well, like 47 or 48, almost every other patient. But we're to keep in mind that this is a randomized trial, and even fever of 37.6 on first day post-op was a complication, because we are to register any adverse event like that. And more than 50% of these complications were Clavien window 1 to 2, requiring nothing or requiring paracetamol, which doesn't really jeopardize patient safety. As the trial that I've mentioned earlier, we didn't find any difference in lymph node harvest. We found 5% of D3 node metastasis. And surprisingly, in these first 100 patients, we found difference, statistically significant difference in N-positive status. This trial is randomized, so on the enrollment, obviously, we have the same population of patients. So either this is a statistical hiccup, or this is a possible potential for better end staging in D3 group. We don't know yet. We will be able to tell more later on. This is just our thoughts. But when we looked into pedicle length, at the first, it was different 10 centimeters to 15, which makes sense, but we went further and we analyzed vascular pedicles separately. And if we look, this is data just from our center. If we look at ileocolic vessel, you'd be surprised, but there is almost no difference between D2 and D3. It's less than centimeter, but if you go back to your surgery, you will imagine that if you're doing D3 and you're taking ileocolic at the root of the mesentery, you're actually very close to the superior mesenteric vein. Actually, you're 6 millimeters away on average from the vein. So for cecal cancer and for cancers when you're taking just ileocolic vessel, D3 is pretty much similar to D3. While for middle colic, this difference was almost 7 centimeters. And for IMA, it was 2.5. So when we're talking about D2 and D3, we have to keep in mind that these procedures are very different for each vessel. And in our data, in our hands, it is very different for middle colics and for IMA, while it's less different for ileocolic vessel. This is something to keep in mind when we're trying to plan our surgeries and to look for indications for extended dissection as well. So that is actually the data that we can comment on, that we can give on these first 100 patients. So the difference between D2 and D3 varies for each vascular pedicle. Again, vascular pedicles are defined by the 10 centimeter rule. D3 is safe and feasible in 12 center hands. Possibly it's better in end staging, which may be the potential for better survival. We don't know that yet. So we're waiting for the results. And to summarize, our approach for optimal lymph node dissection extent is that this extent is actually an arbitrary line, like the polar circle. It does not exist in real life. It's just in our landmarks, in our maps, and we just have to use the same words describing things we're doing. But this line of the best and optimal lymph node dissection can be drawn only by the survival benefit, because we do not actually treating lymph nodes, we're treating the patient. And our aim is to produce the longer and the better life. So the result of removing 5% of metastatic lymph node is actually not a result. The result is survival benefit. And this survival benefit of our patients should be demonstrated in randomized controlled trials. And then we will be able to talk more precisely about the indication. Thank you very much for your attention.
Thank you very much, Alexey. Obviously, it's a very great presentation. Thank you very much. And let me introduce you for your next presenter. We sorry. And now we must say thank you very much, Amjad, for your attention. Thank you for your participation in our meeting. Thank you very much. I hope that we will be next year. Maybe we will meet on our motherland in Russia. I hope it will be good, very good meeting. Thank you. We don't listen to you.
I would just take this opportunity to say thank you once again for everyone. It's really nice to see familiar faces, and it's nice to see that they are safe and they're doing well. Some of you have survived the virus, I know. We've been following your progress. So in some ways, something that doesn't kill us makes us strong. So it has made us strong. And I really hope that very soon, when this pandemic is over, we will be able to meet both in your motherland and in Europe, where I live. You're all welcome. I really enjoyed just listening to the development within Russia, the minimally invasive surgery. You know, you're talking about standardizing training, a fantastic presentation from the Pavelenko School Group. And Alexey Karachun have put together this fantastic trial, which I'm sure would go beyond Russia, because most people are looking forward to the outcome of this trial. And seeing Arsen Rasulov doing very well and looking as young as ever, and Alexey being the same, it's a pleasure being here. And I hope that we will meet again in person, in flesh, very, very soon. Wish you all very, very good luck and be safe. Thank you.
Thank you, Amjad. Thank you. It was good to see you. Thank you very much.
Bye-bye.
Bye.
Уважаемые коллеги, все-таки у нас идет трансляция на сайт. Идет трансляция у нас, у нас идет трансляция в том числе на YouTube, и здесь у нас остались коллеги с других, иностранные коллеги. У меня все-таки предложение обсудить, мы переходим на русский язык, и для них переводят наши переводчики на английский, или продолжаем на английском. Алексей Михайлович, у вас всегда точное мнение по этому поводу. Скажите ваше мнение.
На самом деле можно, наверное, на русский перейти. У нас же аудитория 99,9 русская сейчас.
Поддерживаете?
Да, конечно. И у нас же смотрят еще в YouTube часть наших коллег, поэтому по-русски, наверное, было бы удобнее. Я имею в виду с наших периферий.
Да, хорошо. Тогда, уважаемые переводчики, вы готовы, да, транслировать? У нас все равно многие на английском. Ну, хорошо. Ну, тогда мы продолжим. Я просто хотел бы поблагодарить всех наших участников, отечественных наших друзей, тех, кто сейчас остались. Огромное вам спасибо за ваше терпение. Возможно, какие-то моменты мы не совсем учли в планировании, да, сегодняшней презентации. Надо учитывать, что разница во времени очень большая, и многие из них просто действительно не могли выступить. Я предлагаю передать слово Арсену Османовичу вам и предложить вам выступить с вашим докладом. Мы можем сейчас, чтобы сократить время перерывов, сократить время презентации, если это есть необходимость, но не обязательно. Поэтому, Арсен Османович, пожалуйста.
Окей, сейчас демонстрация экрана. Так, хорошо. Но у меня презентация все равно на английском, и где-то я теперь буду стараться переводить ее обратно, но надеюсь, что будет все понятно. Этот доклад, он основан на результатах исследования, перспективного исследования, которое мы в свое время провели в отделении онкопроктологии онкологического Российского онкологического центра Блохина. И он был посвящен анализу непосредственных функциональных результатов различных техник реконструкции прямой кишки. Все это было сделано, учитывая то, что существует такая большая проблема, как синдром низкой передней резекции после тотальной мезоректомэктомии, который чаще всего производится по поводу рака. И этот синдром включает в себя вот такой достаточно сложный комплексный синдром, включает в себя проблемы с держанием, с императивными позывами, фрагментированный частый многомоментный стул, проблемы с опорожнением и повышенное газообразование. К сожалению, достаточно большое количество пациентов страдает от этого синдрома, по некоторым данным аж до 90%, и почти у половины из них он достаточно сильно выражен, что, естественно, сказывается на качестве жизни этих больных и очень серьезно их ограничивает. Основные факторы риска этого синдрома – это проведенная ранее предоперационная лучевая терапия, это длина удаляемого сегмента кишки, особенно если, в данном случае мы говорим о тотальной мезоректомэктомии, особенно если уходит часть внутреннего сфинктера в препарат. Это способы реконструкции, наличие или отсутствие резервуарной какой-то конструкции. И, соответственно, такое осложнение, как несостоятельность анастомоза после операционного периода. Существуют различные методики реконструкции прямой кишки после тотальной мезоректомэктомии. Наиболее используемые это J-pouch резервуар, поперечная колопластика и так далее. Ну а из анастомозов, конечно, так называемый латеротерминальный анастомоз, анастомоз бок в конец. В этом исследовании мы сравнивали три вида. Это J-резервуар, это анастомоз бок в конец и анастомоз конец в конец. Исследование было проведено в 2014 по 2017 годы. По результатам этого исследования была защищена кандидатская диссертация, были оценены функции. 95 пациентов были включены в это исследование. Исходно включались туда пациенты с опухолью среднеампулярного отдела преимущественно, без отдаленных метастазов. Как правило, это образование Т2, Т3. И в исследование не включались больные, у которых была исходная инконтиненция, или ранее выполненные резекции, генерализованные больные, возрастные пациенты и так далее. Техника была стандартизована, то есть тотальная мезоректомэктомия выполнялась всегда одинаково. Минимальный дистальный клиренс осуществлялся на уровне 2, то есть был не менее 2 сантиметров. Если формировали J-pouch, то длина колена не превышала 5 сантиметров. А если формировали анастомоз бок в конец, то культя не превышала 3-5 сантиметров. Все анастомозы выполнялись аппаратным швом, и, соответственно, это была колоректальная анастомоза, не колоанальная анастомоза, и во всех случаях выполнялась проксимальная колостомия или илиостомия. Чтобы оценить функциональные результаты в сроке 3, 6 и 12 месяцев пациентам раздавались опросники, они приглашались на повторную консультацию, и изучался так называемая шкала Ларс-шкала, Low Anterior Resection Syndrome, Векснер шкала и шкала качества жизни, связанная с анальной инконтиненцией. Кроме того, проводились манометрические исследования. 95 пациентов всего участвовало в исследовании. Они были распределены в 3 группы по 30 человек. И исходно планировалось, что группы будут одинаковые. Однако в процессе исследования из группы J-pouch резервуаров 8 человек, они были конвертированы в другие группы. Один из них в бок в конец и 7 человек в конец анастомозы по различным причинам. Причины, когда мы проанализировали, были следующие. Это узкий таз у 2 пациентов, в результате чего J-образный резервуар просто мог не поместиться. Это висцеральное ожирение у 3 человек. И в 3 случаях недостаточно было кишки для формирования резервуара. Но нужно отметить, что 5 из 8 пациентов это были мужчины. Большинство операций выполнялось малоинвазивными доступами. Открыто выполнен только 21% операций, и четверть пациентов была оперирована с помощью трансанального доступа, трансанальной мезоректомэктомии. И как еще я говорил еще раз, во всех случаях анастомоз отключался, выполнялась колостомия или илиостомия. Группы были сравнимы по всем характеристикам, за исключением лиц женского пола, которых было больше в группе с анастомозами конец в конец. Анализ хирургических интраоперационных особенностей выявил, что при формировании J-pouch резервуара нам приходилось в подавляющем большинстве пациентов делать высокую перевязку и мобилизацию левого изгиба для того, чтобы обеспечить достаточную длину неизводимой кишки. Это было достоверно больше в сравнении с другими группами. Частота послеоперационных осложнений была почти одинаковая, с небольшой тенденцией к увеличению в группе анастомозов конец-конец, и при этом не было различий по несостоятельности несостоятельного колоректального анастомоза в послеоперационном периоде. Что касается функциональных результатов, J-образный резервуар продемонстрировал наилучшие показатели в плане объема, что, в общем-то, и неудивительно, учитывая технические особенности этой конструкции. В сроке 3, 6 и 12 месяцев объем неоректум был больше в группе J-образного резервуара, но нужно отметить, что в течение этого периода происходила адаптация кишки, и объем низведенной кишки, он увеличивался и при других техниках реконструкции в том числе. Но способ реконструкции, предположим, не повлиял никаким образом на показатели манометрии, это максимального давления и давления покоя в анальном канале. Они независимо от способа реконструкции улучшались в течение времени, но в основном это в первые полгода, с 3 до 6 месяцев. Что касается так называемой шкалы Векснер, то наилучшие результаты, которые, как мы знаем, оценивают в большей степени все-таки это недостаточности, инконтиненцию. Наилучшие результаты были в сроке 3, 6, 12 месяцев, опять-таки у пациентов с резервуарами. Но нужно сказать, что у пациентов с анастомозом бок-конец, терминолатеральным анастомозом, также были хорошие результаты, достоверно лучше в сравнении с анастомозом конец-конец в сроке 3 и 6 месяцев. Правда, к 12 месяцам эти два вида анастомозов сравнялись по этому показателю, тогда как J-образный резервуар продолжал оставаться наилучшим. В отношении, в соответствии со шкалой синдрома низкой передней резекции, также наилучшие результаты были продемонстрированы при применении J-образного резервуара во все временные отрезки после операции. При этом анастомоз бок-конец также демонстрировал лучшие показатели в сроке 3-6 месяцев. Да. К 12 месяцам показатели приближались к показателям анастомоза конец-конец. Вопрос качества жизни в данном случае он был очень довольно-таки наглядным по двум позициям. И что касается образа жизни, то также и у пациентов с J-образным резервуаром отмечалось преимущество на всех временных отрезках, это 3, 6 и 12 месяцев. Вот, в то время как анастомоз бок-конец демонстрировал к 12 месяцам после операции примерно одинаковые результаты с анастомозом конец в конец. Таким образом, по результатам проведенного нами исследования было установлено, что все-таки наилучшими характеристиками в плане функциональных результатов обладает J-образный резервуар. Но если не удается его выполнить, а причины для выполнения, они, в общем-то, как правило, технические причины, длина кишки, узость таза, висцеральное ожирение и так далее. Если не удается выполнить J-образный резервуар, то предпочтительным является выполнение анастомоза бок-конец, который технически все-таки более доступен и проще, чем J-образный резервуар, в то же время обеспечивает достаточно хорошие функциональные результаты, особенно в сроке 3-6 месяцев после операции. Благодарю всех за внимание.
Спасибо, Арсен Османович. Огромное спасибо за интересный доклад. Я думаю, что мы сейчас не будем вопросы задавать, а зададим уже вопросы после того, как выслушаем Алексея Михайловича. Алексей Михайлович, пожалуйста, слово вам. Ваш доклад с нетерпением ждем. Алексей Михайлович, спасибо. Мы слушаем вас, Алексей Михайлович, ваш доклад.
Are you seeing my screen?
Yes, yes.
Okay, dear Chairman, dear colleagues, dear friends, it's my honor and pleasure to present here today. Especially, I'm happy to talk English. No concern. 2018 was unfortunately marked with the death of Stephen Hawking, an ingenious scientist who managed to travel to far worlds just with his laptop and his mind. We will try to do something similar, as anastomotic leak are rare events. In order to analyze any outcomes, we need to summarize the data from a large number of patients. If you go to PubMed and enter colon or rectal or colorectal and anastomotic leak and long term, we will get more than 200 results. We identified 82 relevant articles and analyzed their full text. What is the big picture? We are all very well aware that anastomotic leak is accompanied with short-term and functional problems. In short-term perspective, it's increased morbidity and mortality, which is obvious, and we will not discuss with this today. functional outcomes are not as easy to analyze. Studying outcomes more than 600 patients enrolled in classic trial, it was shown that postoperative complications have adverse effects in long-term quality of life, physical role, and social functioning and body image, as well as for mobility, self-care, and pain or discomfort. When 341 intersphecteric resections were researched by Japanese surgeons, all patients were divided to 3 groups: control, patients with major leak, and with complete anastomotic dehiscence. The probability of stoma closure decreased with increase in severe of leak. Anastomotic stricture was less than 2% in patients with no leak, while there were 16% of patients with major leak who had anastomotic stricture. More than a third of patients with anastomotic dehiscence had anastomotic stricture. When continence function was estimated in 2 years after surgery, it was similar in control group and major leak groups, while after anastomotic dehiscence, it was still worse. French surgeons analyzed risk of definitive stoma formation at 10 years after ultra-low sphincter pharynx rectal resections. Surgical morbidity, not only anastomotic leaks, was an independent risk factor for definitive stoma with odds ratio of 3. Surgeons from the United States studying 800 patients concluded that even preservation of anastomosis in case of leak impair quality of life. Association of anastomotic leaks with long-term outcomes are controversial. There is some data that there is no association with oncological outcomes. More than 500 patients were followed by 10 years and no decrease in cancer-specific survival. More than 3,000 patients were analyzed and no connection of abdominal pelvic sepsis with overall survival in matched analysis was found. It's worth saying that in univariative analysis, there was an association with worse overall survival, and 2/3 of patients received hemorrhagation prior to surgery. All patients in this study had an hemorrhagation, and no relation with long-term outcomes was observed. At the same time, there is data that anastomotic leak is associated with poor long-term outcomes. Negative impact of long-term outcomes in colorectal resection was first reported in 1991. It was shown that recurrence was 46% in leak group versus 18% without it. Cancer-specific mortality in 2 years was 37% after leak compared to 12% without leak. Since 1991, a number of papers was published demonstrating long-term impact of anastomotic leak. At the same time, there are some articles finding the impact of long-term outcomes only after colonic resection. Other researchers contrary find difference only after rectal resections. There are 3 meta-analyses in these studies. The first one included 11 studies and 13,000 of patients demonstrating higher cancer-specific mortality and local recurrences with odds ratio of 1.3 and 1.6. Another included only randomized trials, which resulted in 5,000 patients. Worse overall survival in leak group was found with hazard ratio 1.48, worse disease-free survival with hazard ratio 1.22, and less symptomatic leakage in case of diverting stoma present was noted. The largest analysis included 13 studies and 21,000 of patients. Local recurrence in rectal resections was worse after leakage with odds ratio of 2, when rectal and colon resections were reported together. Odds ratio for local recurrence was almost 3. Odds ratio for distant recurrences was 1.4 and 1.75 for patient-specific mortality after leak. The nature of connection of leaks and long-term results is still not clear. There may be a common reason for these two outcomes, like difficult surgery, which will result in high anastomotic leak rate and poor long-term outcomes. At the same time, anastomotic leak may compromise long-term outcomes via sepsis. It's well demonstrated that sepsis decreases overall survival even without cancer. In this report of 2,700 patients, including 3 months mortality, 1 year mortality was 30%, 2 years mortality 43%. There was no cancer in this study, only sepsis. Mean age was 76 years, which may be the reason of such high number. Nevertheless, there is an not unusual age for colorectal resections. In young patients of 18 to 45 years, 1 year mortality was 7 times higher than control, and in 2 years, 5 times higher. Again, it's just the influence of sepsis. Sepsis alone shouldn't be responsible for all long-term outcomes, as disease-free survival, local recurrence, systemic recurrence, and cancer-specific survival are also decreased. There should be another way. Usually recurrences after leak are explained by translocation of exfoliated cancer cells from the bowel. It is shown that systemic inflammatory response and high concentration of cytokines accompanying sepsis may stimulate tumor growth. When patients with Dukes B and Dukes T were divided according to inflammatory response after colorectal resection by the level of CRP, it turned out to be a powerful predictor of long-term outcome. You can see that Dukes B with elevated CRP has similar prognosis with Dukes C without elevation of CRP. For Dukes C, high CRP decreases 3-year survival almost twice. The inflammatory response on the leak is also of important value. Suppression of neutrophils and hazard ratio of 2.6 for disease-free survival. Decrease of value calculated from albumin level and lymphocyte count had hazard ratio of 3.5 for disease-free survival. There is data up to date regarding long-term results of anastomotic leak. And according to this data, the main take-home message is try to avoid anastomotic leaks. But seriously, is anywhere one in this audience who is not trying to avoid leaks? Or anywhere who knows how to avoid them completely? What else can we conclude? That the deviating stoma are neutralizing the effect of leak. Well, it's better, but rather obvious. So actually, what is this all about? When we are talking about cell getting outside the ball through the leak, which cells are we talking about? We are discussing R0 surgery with clear margins. Where do these cells come from? And what are the source recurrence? There is an interesting data on breast cancer patients. Wound complications were a significant predictor of systemic recurrence, and no association with local recurrence was observed. There are wound complications after breast surgery, no exfoliated cells from the lumen there. So, from this point, we don't have much data, but let's try to analyze the information and try like Stephen Hawking to imagine how things may work for mentioned outcomes to be explained. Let's have a look at a constellation called human. We know that there is a tumor, and we know the margins of this tumor. We perform an R0 surgery and obtain negative margin in the specimen. So, where are those cells coming from? Are there any cells in the lumen? When washout of rectal stump were analyzed, it was shown that after first 15 milliliters washout, 11 of 14 patients had positive cytology. After fifth washout, half of patients. Even after 10th, 5th milliliters of washout, 4 out of 14 patients had still had positive cytology. So it's obvious that when the tumor is present, cancer cells in the lumen can be found in majority of patients. When 10 dognuts after anterior resection were assessed by histology as negative, 9 of 10 had cancer cells on them. What about circulation in blood cancer cells? This is chart of percentage of patients with isolated circulation cancer cells in blood after surgery. We can clearly see that significant amount of patients have circulation cancer cells even after tumor removal. This is recent meta-analysis of circulation tumor cells studies. The rate of positive circulation tumor cells in non-metastatic colorectal cancer patients varied from 20 to 70% of patients. If we consider adjuvant chemotherapy to be effective, there should be an aim for it, so we should assume that there are cells in the liver and in lungs as well. So there are cells in washout from lumen, in blood, in liver, in lungs, and we are still calling it clear margins. Does it make any sense? It seems that there are no margins at all. It is the gray zone, as there are cells everywhere, and it means that is certain equilibrium of gray zone between immune system and cancer cells. If immune system can effectively fight the cancer and control it, we observe remission. Even if the cancer cells are still present, they are under control. If for some reason cancer cells manage to get out of immune system attack, we observe progression. There is some systemic factors that can influence this equilibrium. Chemotherapy and effective anti-tumor immunity will serve patient benefit, while tumor mutation or sepsis, which we discussed earlier, may help cancer cells to escape. From this point of view, there is a change of paradigm. We are not only trying to obtain negative margins, but to provide victory for immune system in gray zone equilibrium. That's a model, not proven, but explaining what we are seeing. If we continue our mind to further, we wish we could get results of randomized trials, but of course, we cannot randomize leak and no leak, morbidity versus no morbidity, inflammation versus no inflammation, or major trauma versus minimal trauma. But actually, if we can do it, this is to randomize to open to lab. If you look at the results of classic trial, the trials with the worst margin among all colorectal trials, 12% of positive circulation CRM in lab group versus 6% in open. But even with these poor margins, if we have a look at 10 years outcomes, we will see completely different results. Better median survival with trend towards statistically significant difference in survival. We can't be sure, but it may be due to positive change in gray zone equilibrium due to less trauma and quicker recovery. There's just a third possibility. In this perspective, if we think that this course of events is possible, it means that anastomotic leak may shift equilibrium in gray zone against patient's benefit. Therefore, we should always keep the equilibrium gray zone in gray matter of Sargent's gray. Thank you very much, and sorry for waiting. I have finished, guys.
Большое спасибо за доклад. Есть ли вопросы
I can't understand you, Rustem.
к нашим
I can't
докладчикам?
understand you. Please speak
Алексей
English.
Михайлович, вас очень
Вы
плохо
по-русски не
слышно.
понимаете, Алексей Михайлович?
О, Михаил.
С
Да,
удовольствием
если...
прослушаю ваш
Да.
доклад. Рад вас видеть очень.
Кто побрил, Михаил Михайлович?
А? Приветствую всех.
Спасибо. К нам присоединился Михаил Михайлович Давыдов. Очень приятно вас видеть. И я просто тогда, чтобы продолжать нашу конференцию, есть доклад в чате. Арсен Александрович, сначала к вам. Вот при формировании G-pouch или формировании анастомоза бок в конец, что, по вашему мнению, важнее? Более низкий риск несостоятельности или функциональный результат?
Ну, на самом деле, конечно, и тот, и другой фактор, они очень важны. Если говорить про причины, по которым мы делаем J-pouch или анастомоз бок в конец, то в первую очередь это причины, конечно, функциональные. То есть мы хотим каким-то образом улучшить качество жизни этих пациентов и уменьшить тяжесть проявлений синдрома низкой передней резекции, поэтому делаем эти резервуарные конструкции. Но как показывают исследования, наше исследование, к сожалению, не подтвердило, но как показывает большинство исследований, все-таки частота несостоятельности именно вот циркулярного колоректального анастомоза, она ниже при анастомозе бок в конец, да, в сравнении с анастомозом конец в конец, что тоже является еще одним дополнительным преимуществом. Но вот по моему мнению, предпочитать наиболее золотая середина, конечно, это анастомоз бок в конец, поскольку он позволяет и улучшить функциональные результаты, и уменьшить частоту несостоятельности анастомоза.
Хорошо, спасибо большое. Я думаю, что вопросом удовлетворены. Алексей Михайлович, вы с нами еще?
Да, я с вами. Просто выключил звук, чтобы нагрузка на интернет была меньше.
Хорошо. Чтобы провода не перегрелись. Понятно. Алексей Михайлович, вопрос. Вот очень тоже интересный доклад. И спасибо тоже, что вы его сделали на английском. Вопрос к вам. То есть у нас несостоятельность анастомоза рассматривается не только с непосредственно отдаленными результатами. Да? И как вот на ваш взгляд, вот мне очень понравилось исследование, где вы говорили о том, что разные виды несостоятельности, да, ведь существуют. То есть очень большая несостоятельность, где там зияние идет, я правильно так понимаю? То есть все равно разные уровни несостоятельности, разные степень несостоятельности по-разному окончательно влияет на результат функциональный.
Ну, это не мои данные, это данные
Я
литературы.
понимаю, да.
По данным литературы, да.
Скажите, пожалуйста, Алексей Михайлович, а вот особенно при низких резекциях, все равно при низких резекциях частота несостоятельности, она, естественно, выше, особенно после химии, радиотерапии. Скажите, пожалуйста, вот ваше отношение, ваше отношение к низким передним резекциям при химиолучевой, после химиолучевой терапии, особенно когда есть высокий риск несостоятельности. Все равно мы понимаем, что вот у Таши Куреши был вопрос о том, что опыт хирурга учитывается, не учитывается. Мы это иногда называем интуицией, да, ведь в принципе, как вы считаете, вот при выборе сохранения непрерывности кишки, вот ваш опыт, а в каком все-таки варианте вы отказываетесь от выполнения низкой резекции и переходите, например, на обструктивную резекцию или эксирпацию? Ну, эксирпацию – это уж отдельный вопрос, именно, допустим, на обструктивную резекцию. Когда вы отказываетесь от наложения анастомоза?
Я, честно говоря, вопрос не очень понял, потому что такой, пока его задавали, так, ну...
Вы забыли начало. Тогда да, я повторю.
Виляли по лабиринту. Я просто как я отношусь к лучевой терапии, или как я отношусь к анастомозу, или как я к чему отношусь?
Вот смотрите, как вы относитесь, как вы выбираете тактику ведения пациентов после химиолучевой терапии при низких раках, когда вот вы лично отказываетесь от наложения анастомоза?
Я понял. Я думаю, что я здесь вряд ли скажу что-то новое, поскольку чем ниже расположена опухоль, тем больше показаний химиолучевой терапии. И согласно современным стандартам, даже опухоли категории Т2, N0, но локализующиеся в нижнем полярном отделе прямой кишки, это практически все поголовно кандидаты для химиолучевой терапии, согласно стандартам. Поэтому что хочу сказать. Я отношусь к лучевой терапии как к неизбежному злу для хирурга, но злу неизбежным, поскольку по литературным данным применение химиолучевой терапии до операции статистически значимо снижает частоту местных рецидивов. Что касается формирования анастомоза, то у нас абсолютными показаниями к выполнению брюшно-промежной экстирпации прямой кишки являются инвазия опухоли в сфинктер, даже во внутренний сфинктер, и в леватор. В такой ситуации мы не рассматриваем вариант формирования первичного анастомоза, мы должны выполнить брюшно-промежную экстирпацию прямой кишки. Если мы можем выполнить низкую переднюю резекцию прямой кишки с формированием степлерного анастомоза, мы стараемся делать во всех случаях, но понятно, что прикрываемся отключающей стомой. Если же речь стоит о том, что пациенту необходимо выполнить какой-то из вариантов интерсфинктерной резекции, то вот здесь мы с пациентом очень подробно проговариваем. Потому что оптимисты говорят, что удовлетворительную функцию удержания мы можем получить у 50% больных, а пессимисты говорят, что отвратительный результат у 50% больных. То есть эти два человека с разной стороны смотрят на пресловутый стакан, наполовину заполненный. И вот Арсен говорит, что он даже наполовину полон, а я говорю, он наполовину пуст. И ответа здесь, честно говоря, нет. Здесь дальше уже вот преференции хирурга. Я считаю, что пациенту лучше иметь хорошую стому, нежели великолепно сформированную интерсфинктерную резекцию с изливающимся калом на бедра. Поэтому,
Спасибо.
опять,
Спасибо. Да, я могу слово вставить здесь комментарий, потому что очень интересная тема такая, Рустем Талгатович поднял. Вы, Алексей Михайлович, как всегда, очень так вот грамотно ушли немножко в сторону в ответе. Я просто конкретизирую его сейчас.
Это опыт.
Речь идет не о показаниях к экстирпации или интерсфинктерной резекции. Насколько я понял вопрос Рустема, речь идет именно о тех пациентах, кому вы можете технически выполнить низкую переднюю резекцию, можете, но воздерживаетесь от этого и не делаете анастомоз. По каким причинам? Если такие у вас кейсы есть?
Только если это конкретно пациента не люблю. Если мы можем сохранить задний проход, мы должны его сохранить. Поскольку это
если у него анальная инконтиненция 2-3 степени исходная, и он еще и облучен, и вы смотрите его ректально и видите, что тонуса сфинктера вообще никакого нету, а при этом опухоль на 7 сантиметрах, вы ему сделаете анастомоз?
Да, потому что в такой ситуации он уже привык к недержанию, и его качество жизни не пострадает.
Понятно.
Да, Илья Леонидович.
Я позволю себе тоже сказать свое мнение по этому поводу. Мы тоже стараемся во всех случаях избежать операции Гартмана, но есть еще одно показание, которое мы иногда учитываем, когда все-таки не формируем анастомоз. Это в тех случаях, когда прямая кишка и толстая кишка забиты калом, который никак не получилось эту кишку подготовить и отмыть. Такой консистенции замазкообразной, и в этих случаях у нас было пару ситуаций, когда мы формировали анастомоз, формировали превентивную трансверзостому, и тем не менее случалась тяжелейшая несостоятельность, все равно с развитием тяжелых генетических осложнений, несмотря на наличие превентивной стомы. И вот в этих редких случаях, это бывает очень нечасто, мы все-таки, когда видим такую кишку, как колбаса, забитую калом, мы все-таки не формируем анастомоз, а обструктивную резекцию выполняем. Но это бывает там единичные случаи за год, скажем, 2-3.
Ну, вот я тоже тогда поясню.
Зрение достаточно хорошо, но вот такие ситуации, когда кишка заполнена калом, они, как правило, редко бывают, когда эта опухоль локализуется в среднем или нижнем полярном отделе прямой кишки. Пациенты готовятся, и у меня, во всяком случае, на практике могу сказать, что такого не было. А вот верхняя полярный рак, колоректосигмоид, да, если кишка заполнена калом, то мы достаточно, я бы даже сказал, просто формируем показания к обструктивной резекции с последующим восстановлением через несколько месяцев. Извини, Арсен, если перебил.
Да, я продолжу тогда. Я вот, например, поясню свою точку зрения, потому что это вопрос все-таки он достаточно актуальный. Вот если пациент исходно с анальной инконтиненцией, 2-3 степень, он вынужден носить прокладки, он облучен, человек в возрасте, то я стараюсь максимально ему разъяснить до операции, что формирование анастомоза, оно не приведет к улучшению его жизни, что это, наоборот, будет только хуже. И отговорить его всячески от этой операции. Сделать ему одноэтапную операцию, по типу низкой резекции, по типу Гартмана, все. Потому что потом он придет через 3 месяца, стому мы ему закроем, у него там ничего не держится, все валится, потом он будет приходить и рассказывать, как ему плохо. Поэтому лучше вперед я ему объясню и уговорю, чтобы он отказался от операции. У меня такая тактика.
Спасибо большое, очень интересно. Я тоже придерживаюсь мнения, что лучше объяснить, найти консенсус с пациентом,
чем потом у нас, вот на моей памяти было 2, по-моему, случая, когда наши пациенты после закрытия стомы возвращались к оперирующему хирургу и просили ему стому обратно наложить. Да, Илья Ильич?
Я прошу прощения, я еще хотел бы прокомментировать утверждение, что, в общем, как правильно заметил Алексей Михайлович, что лучевая терапия зло для хирурга. Сейчас идет несколько исследований, которые призваны изучить, сравнить эффективность химиотерапии неоадъювантной вместо химиолучевой терапии. И, может быть, вот в этой плоскости лежит некоторый успех в плане того, что химиотерапия неоадъювантная, видимо, меньше дает осложнений или предпосылок для осложнений в плане несостоятельности, чем лучевая терапия. Если окажется, что неоадъювантная химиотерапия может в ряде случаев заменить неоадъювантную химиолучевую терапию, то, может быть, мы сможем достичь более хороших непосредственных функциональных результатов.
Да, вполне возможно, что эта гипотеза, она найдет своих пациентов, которые будут хорошо реагировать на химиотерапию, и эффект у которых будет такой сравним с химиолучевой по степени регрессии и так далее. Вот у этих пациентов вполне возможно, что будет, да, бенефит.
Спасибо большое. Я предлагаю еще немножко потерпеть. У нас осталось 2 доклада. Это доклады наши из Башкортостана. У нас есть 5-минутные, скажем так, для сокращения времени, 5-минутные доклады. И 2 минуты мы буквально прорвемся на 2 минуты для ролика.
After the operation. Under unfavorable conditions, the colonization of the wounded area with bacteria can lead to a serious wound infection with life-threatening consequences. Bacteria enter the wounded area during and after the operation and immediately begin to multiply. The endogenous defenses try to fend off this attack. The bacteria then retreat to areas such as the surfaces of implants in order to continue their undisturbed proliferation. Here, they may form a biofilm, which provides them with excellent protection against defense cells and antibiotics. In addition, they may be able to use the implant as an entrance point in order to reach deep into the tissue. The worst case scenario is that an infection confined to the incision begins to spread via the deeper tissues to the organs. The 3 terms used to describe this process are incisional infection, deep tissue infection, organ space infection. By adhering to all the hygiene regulations, only very few bacteria are able to enter the wounded area during and after the operation, where they begin to multiply. By means of optimally preparing the patient with regard to risk factors, the immune system is in a good starting position to ward off an attack. The inclusion of an antibacterial coating on the suture material means that the surface is neither suitable for undisturbed proliferation nor as an infection entry point. Under these favorable conditions, bacteria may be warded off in time and an infection is prevented.
Спасибо большое за ваше ожидание. И позвольте мне представить 2 доклада. Первый доклад, читаю я, это опыт колоректальной хирургии внедрения у нас, в нашей республике. И второй доклад, посвященный будет скринингу колоректального рака в Республике Башкортостан.
Я буду читать на английском. Надеюсь, что нас еще слушают. Let me to introduce. Да. Так, извините, сейчас 5 секунд. Let me to introduce our region. Republic of Bashkortostan is one of the most developed regions of the Russian Federation. And our region is one of the most beautiful places in Russia. I hope that you will have possibilities to visit our republic in future. Colorectal cancer is the first common cancer among men and women, and the second leading cause of cancer-related death in our region. It has been estimated that 1/3 of patients are diagnosed when colorectal cancer has already spread to the lymph nodes. 1 out of 5 patients is diagnosed with metastatic colorectal cancer. There's a small difference between colon and rectal cancer, but colon cancer with stage 4 is more often. Since 20... Sorry. Презентацию. I'm sorry. I don't... Я не запустил презентацию. Sorry. Сейчас еще раз. This is our republic. And I repeat that colorectal cancer is the first common cancer among men and women, and the second leading cause of cancer-related death in our region. 1/3 of patients are diagnosed with colorectal has already spread to the lymph nodes, and 1 out of 5 patients is diagnosed with metastatic colorectal cancer. Colon cancer with stage 4 is more often. Since 2018, in our region started unique program of colorectal cancer screening with 2-step model. On first step, patients drop biomaterial and health center, and the health center has few functions: monitoring, registration of patient, and referral of patient to colonoscopy in case of positive test. On the second step, patient undergoing colonoscopy, and in case of colorectal cancer, to referral to oncological center for treatment. You see that diagnosed new cases of colorectal cancer in early stage due to colorectal cancer screening. And last year, more than 200,000 tests was performed, and more than 11,000 had positive test. More than 7,000 patients undergoing colonoscopy, and adenoma detection rate was 38%, and 356 new cases of colorectal cancer was detected. Unfortunately, this year colorectal cancer screening failed due to COVID, and nevertheless, this program has good perspectives. Furthermore, colorectal cancer screening gave us new possibilities to develop mini-invasive surgery. We started our different. We started our attempts in 2010 and changed our minds after visit of Portsmouth in 2013. We recognized another culture of lab surgery. We continued our dedication. And next step was masterclass by Amjad Parvaiz with his colleagues Qureshi and Nuna Fuguera in Ufa.
There were 2 operation days, 4 lab procedures with online translation, and there were more and more master classes with serious surgeons. And you see that we obtained experience during 10 years, and last 3 years were more productive. All of this is the result of teamwork of qualified specialists. Unfortunately, this year we have some problems under negative influence of spreading of COVID. More often we have performed lab procedure in case of rectal cancer, and more often there was sphincter preserve procedure operations. I particularly mentioned the results of development of lab surgery in case of rectal cancer, and I would like to show the relationship between 2 approaches, open and lab. You can see that last 2 years we often more often performed lab surgery, lab procedures in case of rectal cancer, and often we talking about low resection with TME, total mesorectal excision. And you see that more of our surgeons after surgery, after performing low anterior resection, prefer colostomy. Post-operative complication, I am talking about Clavien Dindot 3 and 4. were found in 9% of the patients per year. The 30-day mortality rate of 1% and 90-day mortality rate of 1.6% found in our study is comparable to that reported in the literature from the high-volume centers. The commonest surgical complication encountered among our patients was surgical site infections, including anastomotic leakage. We take participation in different international trials, and this video shows us our technical school, and maybe you can see that we also have a small experience in robotic surgery. In conclusion, what do you need for good results? I hope that we have these good results, and I think that you need something for this. At first, it's good team, good mentors, good tools, and good patience. Thank you very much for your attention. Thank you. Спасибо за внимание. Благодарю за внимание всех. И сейчас я предлагаю выступить Абдрахману Рустему с презентацией о скрининге колоректального рака в Республике Башкортостан. Напоминаю, Рустем Рамильевич, 5-7 минут. Спасибо.
Уважаемые коллеги, приветствую всех. Продолжение хирургической тематики. Хочу сказать, что есть действенный инструмент, который мы можем реализовывать. Это скрининг колоректального рака, который несомненно, влияет на ситуацию с ранними формами. Как мы все знаем, прогноз хирургического лечения связан со стадией заболевания, ну и в то же время обеспечивает определенный пул людей, которые не доходят до хирургии, поскольку полипы удаляются эндоскопически, и просто рак не развивается. Тем самым мы реализуем ту самую как бы предикцию заболевания. Как уже было сказано, у нас в структуре заболеваемости и смертности колоректальный рак занимает 2-е место. Мы имеем множество рекомендаций международных по проведению скрининга, мы их все учли и пришли к определенной модели скрининга, которая у нас, несомненно, коррелирует и с российскими рекомендациями в рамках диспансеризации. Отмечу, что, наверное, 124-й приказ является достаточно прогрессивным в той части, что он исключает использование устаревших малоэффективных тестов гвояковой пробы. Наша модель скрининга, она, как Рустем Талгач уже сказал, она, в общем-то, такая трехэтапная. Первое, мы уделяем достаточное внимание приглашению пациентов, составляем поименные списки возрастной группы 40-75 лет. Соответственно, забираем их биоматериал через преклиническое звено, используем иммунохимический количественный тест. Далее у положительных пациентов с положительным тестом проводится эндоскопическое исследование на базе 18 эндоскопических центров. Мы, скажем так, такое трепетное внимание уделили именно первому этапу. Мы используем именно количественный тест, поскольку считаем его оптимальным для проведения именно популяционного скрининга. В то же время мы не исключаем то, что, конечно же, домашние тесты, качественные, они также хороши, но для других целей, именно для самообследования или для обследования малой группы пациентов. Мы также обратили внимание, что эффективность скрининга зависит от той отсечки, которую мы, от уровня котов, который мы устанавливаем в скрининговой программе. В общем-то, тот котов, который у нас установлен, это 50 нанограмм на миллилитр. Это отсечка, которая присутствует во многих международных программах, в том числе в одной из крупных в Голландии. Как я уже говорил, в принципе, алгоритм скрининга достаточно простой. Пациенты с положительным тестом у нас маршрутизируются на 2-й этап скрининга, который представляет собой колоноскопию, и далее реализуется определенный алгоритм в виде удаления обнаруженных полипов или до обследования пациента, если мы все-таки подозреваем у него колоректальный рак. И надо отметить, что мы центры эндоскопии в основном разместили в центрах амбулаторной онкологии для того, чтобы минимизировать движение пациента, то есть ускорить диагностику. Таким образом, мы получили за 2018-2019 год определенные результаты. 2020 год, я сведения не привожу, как уже было сказано, пандемия внесла свое влияние определенное. Мы видим, что у нас результаты программы коррелируют с международными показателями и в части выявляемости, и в части adenoma detection rate. Таким образом, мы можем говорить о определенном успехе этой программы. Конечно же, она требует постоянного совершенствования, и мы планируем реализовывать эти мероприятия. Эффекты от внедрения скрининга у нас, в принципе, очевидны. Это, конечно же, повышение доли ранних форм. Это пациенты увеличились у нас на 1-й стадии, что, несомненно, конечно, влияет на прогноз хирургического дальнейшего вмешательства. И у нас значительно в 2,5 раза увеличилось количество лапароскопических вмешательств по поводу колоректального рака. Проблемы, которые мы выявили, это, конечно же, когда мы с пилотного проекта в Уфе ушли на всю республику, мы заметили снижение эффективности скрининга с 0,32 до 0,18%, ввиду того, что много пациентов у нас не дошло до колоноскопии, и качество колоноскопии не во всех учреждениях не соответствовало критериям качества колоноскопии. Также можно отметить, что малый процент пациентов получали полипэктомию, то есть удаление полипов именно амбулаторно, одномоментно. Им все же все-таки потом приходилось госпитализироваться отдельно для проведения этой процедуры. И также малый процент был пациентов, которым была проведена колоноскопия под седацией. Мы, конечно, считаем, что в перспективе мы будем увеличивать количество значений этих показателей. Что мы планируем делать в дальнейшем? Это, конечно же, инструменты внедрять в информатизации, поскольку нам нужен такой единый регистр этих пациентов, который мы постоянно бы отслеживали с целью уже создания какой-то персонифицированного скрининга в дальнейшем для каждого пациента, проведения массовой кампании по рекламе этого скрининга, поскольку сейчас все-таки, скажем, эти инструменты мы не используем в достаточной степени. Это повышение квалификации врачей-эндоскопистов. Мы участвуем в образовательном проекте «Международный КВАКОЛ». И, конечно же, мы обращаем должное внимание оснащению медучреждений. В рамках нацпроекта мы ежегодно оснащаем учреждения эндоскопическим оборудованием. И закончить свое выступление хотелось бы словами Никколо Макиавелли, который говорит о том, что нет всегда подходящих времен, благоприятных обстоятельств, поэтому не стоит ждать какого-то подходящего момента. Мы, наверное, живем в то самое время, когда мы можем менять ситуацию и спасать жизни наших пациентов. Спасибо за внимание.
Спасибо большое, Рустем. Пока никто не подключился, может быть, я смогу задать вопрос тогда. Вопрос такой. Мы же знаем, что любой скрининг имеет и свои негативные последствия. Есть ли данные по тому, сколько осложнений возникло в ходе скрининговых, ну, в основном, конечно, речь идет о втором этапе, в ходе скрининговых обследований, и к чему они привели, там, летальность, осложнения и прочее?
Мы такую статистику не вели в рамках скрининга, вот именно, но по данным коллег наших эндоскопистов, то есть эти данные, они не превышают каких-то бы значимых показателей, которые есть в статистике в плане перфорации или кровотечений. Вот. Естественно, что мы обращаем внимание на то, чтобы эндоскопические центры были в структуре крупных учреждений, у которых есть реанимация, вот, и они могут быстро, если нужно, клипировать сосуды, вот, или провести операцию какую-то.
Если можно, Рустам Толгаевич, еще вопрос можно задать?
Да,
да, значит, еще тогда такой вопрос. Сколько колоноскопий выполнено в условиях медикаментозной седации по республике и сколько без седации, без наркоза?
Рустам Рамилевич?
Да, если можно, я просто отвечу, что вот у нас всего за 2019 год из 7 тысяч проведенных, более 7 тысяч проведенных колоноскопий, у нас только 10% проведено под седацией, то есть порядка 700 случаев. То есть что мы стремимся к ситуации, когда у нас 80-90% под седацией. Пока ситуация обратная абсолютно.
Да, я поясню еще и в общем, да, коротко, что когда в 2018 году, ну вот команда, наша команда, где Рустем Рамильевич сыграл огромную роль в формировании вот этого скрининговой программы, когда эта программа запустилась, было очень много сомнений, прежде всего даже со стороны многих специалистов, что она вообще жизнеспособна. И были прогнозы, что она заглохнет и работать не будет, но она началась, работает. И самое главное, что благодаря вот этой программе мы выявили много несоответствий уровня оказания помощи, увидели, что у нас не хватает оборудования, и Министерство здравоохранения пошло по пути правильному, оно стало закупать это оборудование, мы включили, вот Адель Альбертович сейчас тоже возглавляет программу по онкологии, да, то есть мы включили эти стойкие видеоэндоскопические программы, но пока не каждая медицинская организация имеет возможность проводить седацию именно из-за или какого-то проблем с оборудованием или, например, дефицитом кадров. Да? То есть где-то это просто нежелание или неумение создать необходимые условия. Но мы видим, что с каждым годом эти возможности улучшаются, люди понимают, что это правильно, нужно. А что касается, мы, конечно, обязательно изучим, Леонидович, вопрос, связанный с осложнениями, потому что мы знаем, что они есть. Это в основном касается полипектомии, это там кровотечения или перфорации отсроченные. Они у нас, в принципе, вы знаете, знакомы с нашей системой. У нас единая информационно-аналитическая система, где эти все вещи мы можем проконтролировать. Кстати, это уже пора и сделать. Спасибо большое. Я знаю, что к нам вернулся Амджад. Он слушает в том числе нас. У нас остался еще один доклад записи, посвященный текущий обзор лапароскопической роботизированной ректальной хирургии в ТАТМЕ. Поэтому я предлагаю сейчас его запустить для того, чтобы мы его послушали. Спасибо.
I'm a colorectal surgeon and I was working. Thank you very much for the opportunity to give this presentation in your meeting. I apologize for not being able to give this presentation live, but unfortunately clinical commitments have this. My aim today is to give you a brief summary of the current evidence of laparoscopic, robotic, and transanal TME. Now, I'm going to start with laparoscopic TME. There's a lot of high-quality studies in laparoscopic TME, the surgical outcomes between open and laparoscopic rectal surgery. And I'm going to go through some of these studies. So first of all, I'm going to start with the classic trial, which was published in 2005. Even though the study was not specific to rectal cancer, about half the cases were rectal cases. Now, conversion rate was high, 30%, and got to remember this was over 15 years ago. And there was a high complication rate, CRM positive rate in the laparoscopic group. So based on the results of this trial, laparoscopic TME was not recommended. However, the long-term oncological data of the study confirmed its safety from an oncological perspective. Now, in 2010, the Korean study was published. The study included 170 patients in each arm, had a very low conversion in positive CRM rate in the laparoscopic group, and demonstrated several advantages in terms of structural outcomes, such as lower blood loss and return to normal function. Moreover, this long-term oncological data confirmed the safety and visibility of laparoscopic TME. Then in 2013, we have the results of the COLOR2 trial. This is a large European trial of over 1,100 patients, whose conversion rate is 70%. Again, the short-term outcomes, blood loss and left stay were favorable on the laparoscopic arm when compared to the open arm. Now, in recent years, we've had the publications of two controversial studies in JAMA, one from the US, the ACOS trial, and one from Australia, the RACA trial. Both are comparing laparoscopic to open. Both are non-inferiority studies. Both are using a composite best characteristics as the primary outcomes. Now, the problem with using composite as your primary composite endpoints as your primary outcomes is that what does this actually mean? Does this necessarily translate to worse surgery? Does it translate to worse clinical outcomes? And both of these studies concluded that they could not prove that laparoscopic TME is not inferior to the surgery. Also, the conversion rate was down from 3% to 9%. Now, even though they cannot prove that laparoscopic is not inferior, the long-term data of the findings showed no difference in disease groups. Now, to summarize the evidence of laparoscopic TME, there are multiple high-quality randomized studies that confirm surgery. Is equivalent, and concern on the special quality of the data articles did not translate to ecological significance from those studies. Now, next I'm going to talk to you about robotic TME. Robotic platforms were developed to address the limitation of laparoscopic techniques. They offer several advantages, such as angulated instruments and their tremometry. Now, unlike laparoscopic surgery, the majority of the evidence in robotic surgery, well, robotic rectal surgery, is based on non-randomized retrospective comparative studies. So the evidence is not of high quality. There is an increased number of studies published in robotic TME, and there are several systematic reviews and meta-analysis of these studies. This is an example from 2015, meta-analysis in comparing robotic to studies comparing robotic to TME, and includes over 2,200 patients, and it demonstrates a lower conversion rate and a quicker time to first flatus and superior urogenital function and urogenital outcomes for the robotic group. This is another meta-analysis published in 2016. Again, it demonstrates a lower length of stay and also a lower conversion rate for robotic TME when compared to lab TME. And also showed a lower rate of complications and of positive CRM resections. Now, this is another meta-analysis, again demonstrating a reduced conversion rate and better urogenital outcomes for robotic TME in the expense of increased operative time. In contrast, there was no difference in length of stay or 30-day readmission between robotic and laparoscopic TME in this meta-analysis. Now, this is a meta-analysis published in the Annals of Surgery a couple of years ago, and again, it demonstrates a favorable conversion rate for robotic TME, but a higher operative time. Now, this meta-analysis, now this is a randomized controlled trial published in 2017 in the Annals of Surgery from Korea. It includes relatively small numbers and demonstrated no difference in short-term outcomes between robotic and laparoscopic TME, with the exception of better sexual function 12 months after surgery for the robotic arm. And this is the roller trial, which is arguably the most widely known RCT comparing robotic to laparoscopic TME. It included over 400 patients and found no difference in any of the short-term outcomes between the two groups. Now, in terms of long-term oncological data for robotic surgery, a study in 2015 and of 2,217 patients show no difference between laparoscopic and robotic TME. And again, this is another study published 2 years later, again from Korea, showing that robotic surgery was a good prognostic factor for overall survival and cancer-specific survival. I would like to briefly go through some of our own research that we published. This is a systematic review that we published on the urogenital function of robotic surgery that found that there was a trend towards better urogenital functional outcomes in males in robotic surgery when compared to laparoscopic surgery. And this was further confirmed in a comparative study from our data that we collected from Portsmouth. We also compared the shorter outcomes of robotic and laparoscopic TME for patients with high risk characteristics, such as those that have neoadjuvant treatment or high BMI, and we observed favorable outcomes for these kind of patients in the robotic cohort. And this is a propensity score match study from 3 centers that we published for obese patients with a BMI of over 30, and we found that in the robotic cohort, patients had a lower length of stay and reduced 30-day readmission rate, but a higher operative time. And finally, I'd like to talk to you about this study that is due to be published within the next few days. It's just been accepted. And in this study, we present the outcomes of 1,130 robotic resections across Europe. And these include 826 robotic rectal resections. And in this study, we have demonstrated that within the framework of a structured training program, colorectal surgeons can safely achieve shorter outcomes to those of their trainers and overcome the learning process while minimizing patient harm. So we're looking forward to the publication of this study. So to put it all together, in terms of robotic surgery, it might offer a better conversion rate than compared to laparoscopic surgery, and it might offer improved urological and sexual functional outcomes, but this is probably in the expense of an increased operative time and cost. Now, and finally, I'm going to talk about transanal TME. I personally don't have any experience in performing TME, so what I'm presenting you is based on the reading I've done and not on any personal experience. Now, like robotic TME, most of the evidence is of moderate to low quality. There are no published large-scale randomized controlled trials in transanal TME. Now, to start with, it is worth noting that preliminary studies reported complications that we were not used to with the abdominal approaches, such as urethral and bladder injuries. However, the results of the TAT-TME registry, published in the Annals of Surgery in 2017, were fairly acceptable, supporting its safety and feasibility. And as you can see, the conversion rate was relatively low, and there was a low number actually of complications such as urethral or bladder injuries. Now, this is a meta-analysis published within the last few years that demonstrated better complete TME rate and reduced CRME positive circumferential resection margin, and also reduced operative time for transanal TME when compared to laparoscopic TME, but with no difference in any of the other examined short-term outcomes, such as lymph node yield, complications, conversion, blood loss, anastomotic leak, reoperation, or length of stay. Now, this is a meta-analysis published this couple of years ago. This study again shows a reduced positive CRM circumferential resection margin for transanal TME when compared to laparoscopic TME. But as you can see from the forest plot, this is only just statistically significant. And now finally, this is a meta-analysis published this year, again demonstrating a favorable R0 resection rate for TAT-TME when compared to laparoscopic TME, and also a better lymph node yield and a lower conversion rate with equal complications, anastomotic leak, and operation time. However, it is again worth reiterating that the differences are actually small, so therefore unlikely to be clinically significant. But more importantly, that these meta-analysis and systematic reviews are actually based on low quality studies, and therefore their conclusions have to be taken with a pinch of salt. And of interest is that despite the previous meta-analysis demonstrating a better R0 resection rate for TAT-TME than compared to laparoscopic TME, most of you will well know of this publication, the BJS, last year from the Norwegian Cancer Registry, that has put a real stop in TAT-TME, or at least a break on TAT-TME. And this data showed that there was actually a high and early local recurrence rate for TAT-TME with a different kind of pattern and a different characteristic pattern than what we're used to with laparoscopic, robotic, or open TME surgery. And later this year, further data showed that actually the local recurrence rate at 2.4 years was 11.6% after TAT-TME, when the data from other operations in the Norwegian Colorectal Cancer Registry showed that the local recurrence rate of other procedures was only 2.4%. And as a result of that, the Norwegian government suspended the use of TAT-TME in Norway. Now, even though a lot would have thought that would be the end of TAT-TME, data published from Holland the same year actually showed reasonable local recurrence rates. And this has been further confirmed from other multiple studies from different countries, actually showing reasonable local recurrence rates with local 2 to 3 year local recurrence rates varying between 3 to 4%, which is arguably acceptable. Now, the good thing is that there are 2 large randomized controlled trials underway for transanal TME, comparing TAT-TME with laparoscopic TME. One of them is the COLO3 trial, and the other one is the ETAP Greco 11 trial. And then these studies are likely to provide good quality evidence on the outcomes of TAT-TME when comparing them to laparoscopic TME. So now to put everything together, to summarize everything for TAT-TME, it has been suggested that TAT-TME leads to a lower R0 resection rate. However, there have been concerns regarding some of its complications and its oncological outcomes. Now, hopefully, large-scale RCTs underway will provide further evidence into this. So to end and put everything together, there is good evidence that laparoscopic surgery results in better, shorter outcomes when compared to open surgery. There is no strong evidence to show that robotic or transanal TAT-TME is superior to laparoscopic TME, and it is important that surgeons go through a structured training program if learning a new technique. Finally, surgeons should use whichever technique they feel most comfortable with and according to their local resources. Thank you very much for your time, Thank you for giving me the opportunity to give this presentation. And once again, I apologize for not giving this presentation live and I'm not able to take any questions. Thank you.
Thank you very much for your presentation. I think that we have no question for presenter because he not here. And Amjad, are you there?
Yes, Rustam, I'm here. I listened to some of your presentations as well. Sorry, I had to leave earlier for a hospital, but I joined in, and I was very impressed by looking at your data in particular to see the progress you have made in UFA. So very impressive.
Thank you very much, Amjad. I think that we can to finish our meeting, and I hope that all of participants have had a good practice today. Maybe next year, Amjad, we can see you in Ufa, in St. Petersburg, in Moscow, with Ilya, Karachun, Arsen. Thank you very much for your participation, for your support, and we very glad to see you today. Maybe Ilya says something.
Sure.
Ilya? Илья не слышит? Илья?
Да, сейчас слышу.
На английский, если переключишься канал, пожалуйста, скажи Амджаду что-нибудь. На английский канал переключись, пожалуйста.
Я могу по-русски сказать, а меня переведут, если что, да?
Да, конечно.
Ну, я прежде всего хотел сказать большое спасибо команде Рустема Талгатовича, потому что набрать такое количество звезд, хирургических звезд в одном месте очень непросто. И большая ответственность. Более того, многие из тех, кто сегодня выступал, являются нашими учителями. И в очередной раз очень приятно было сегодня их видеть здесь и общаться с ними. И я действительно надеюсь, что когда-нибудь мы можем увидеться. Я хотел бы отдельно, конечно, поблагодарить еще раз профессора Амджада Парваиза за то время, которое он уделяет нам всем, российской колоректальной хирургии вообще. И я думаю, что каждый здесь сегодня выступающих может, ну, за исключением, наверное, Билла Хилда, может сказать, что в той или иной степени он ученик Амджада Парваиза, и нам это очень приятно. Спасибо всем огромное, это была прекрасная конференция.
Позвольте тоже мне представить слово Адель Альбертовичу, как нашему руководителю заключительно. Да, Адель Альбертович, пожалуйста.
Если можно, я тоже по-русски скажу. Вот, на самом деле мне приятно видеть коллег-колопроктологов, потому что я как представитель урологов многому в своей жизни учился у вас. Во-первых, вы все-таки лидеры в плане малоинвазивной хирургии, и когда мы лет 5 назад начали фаст-трек при простатэктомиях наших лапароскопических, цистэктомиях, то мы ориентировались на результаты 15-летнего опыта проктологического в этой области развития хирургии нашим пациентам. Поэтому хотел бы выразить вам свое уважение, благодарность, поблагодарить Рустема Талгатовича за замечательно проведенную конференцию. Очень мы рады видеть таких известных мировых лидеров, лидеров российских в колопроктологии сегодня, и пожелать дальнейших успехов в развитии и с окончанием этой пандемии, конечно же, встретиться в центре России, в географическом центре России, в Республике Башкортостан, в городе Уфа, на базе клинического онкологического диспансера, всем вместе и провести мероприятие очно.
Еще раз, Амджад, огромная благодарность. В России мы вас любим, мы увеличиваем количество бань, готовимся к вашему приезду. Поэтому мы надеемся, что мы увидимся с вами. Спасибо вам огромное за ваше участие, за тот вклад, который вы делаете и сделали сегодня особенно, за ваше активное участие в этой конференции. Амджад, огромная вам благодарность. Мы в России вас очень любим.
Спасибо, спасибо.
Thank you. Всем спасибо большое. Мы считаем нашу конференцию завершенной. До свидания.
Thank you very much. Take care, everybody. Bye-bye.
Bye.